try to update the evidence on this important relationship. So what exactly is the evidence? In 1996, the Institute of Medicine published a report which basically said that there is no evidence on a relationship between nursing workforce and patient safety. It was not meant in a negative way, but they just meant to say that there was really no evidence. There were no research data available. So it was a call to action. And this call to action was mainly heard in the US at first. In the US, researchers at predominantly the University of Pennsylvania started creating this evidence from the early 2000s in the International Hospital Outcomes Study. Now, about 25 years later, this is what we know about this relationship. So, first of all, people started looking at the effect of nurse staffing on healthcare worker outcomes as well as patient safety. So these are relationships 1 and 2. The more patients nurses have to take care for, the more likely these patients die, the less likely these patients are satisfied with their care. The more likely these patients have longer length of stay, the more likely these patients have increased readmission rates. So we have both subjective and objective outcomes in terms of this patient safety. In terms of health and job satisfaction, there is classic satisfaction with work. There is also the relationship with intention to leave. There is a relationship with burnout, but also absenteeism rates, presenteeism, etc. So what I added on this slide are some systematic reviews, the most recently available systematic reviews that evidence this relationship. Now, a few years later, people also started to be interested in the work environment, the quality of nurses' work. And also here, similar relationships have been found. The better the work environment, the less likely patients are about to die and the more happy nurses are. Those are relationships 3 and 4. Importantly, there are also, it's not displayed on this slide, but there are also associations between nurse staffing and work environment. If you invest in nurse staffing, the added value is only maximized when nurses work in quality work environments, when they have a positive work environment. Now, over the past 5 years, we have become more and more interested in the mechanisms of this relationship between nurse staffing and work environment on the one hand, and outcomes among patients and nurses on the other hand. This is what we call scope of practice, and I think it's also a very relevant topic in terms of health workforce planning. Scope of practice is what nurses and other healthcare providers do in their daily job. It's about the tasks they do, but it's also about the tasks they want to do but cannot do because they lack the time to do that. And especially the latter one, this topic that we call care left undone or missed care, not being able to adequately have surveillance of your patients, not being able to do all the care that you want to, has been a mechanism in the relationship between less so for job outcomes, but even more so for patient safety and quality of care. So this is what we know to date, and this is what you should take away from this session, in fact. But now I will take a look under the hood and see what is the evidence exactly for these associations. What I will primarily do is look at RM Forecast. RM Forecast was an FP7 funded project funded by the European Commission between 2009 and 2011, in which we evidenced these associations in Europe. Like I said before, what we see is that most of this research translates from the US to Europe, but recently, especially when we're talking about the mechanisms, we see that as European researchers in the UK, for example, are on the front line of creating new evidence here. So RM Forecast, like I said, was a European project, and it was a very big project. And in fact, it was more than a European project, or it has become more than a European project. Originally, it involved 12 European countries, both from Northern Europe, Southern Europe, Eastern Europe, a little bit Eastern, but also predominantly in the West. Yeah? You see that we don't have any countries here, but Walter is still actively working on involving countries in the east of Europe. But you also see that similar initiatives originated in the US, China, Chile, Australia, etc. So RM forecast, while the original funding period was from 2009 to 2011, is still alive today. From this research, we've published over 100 peer-reviewed papers, including papers in the Lancet, BMJ Quality and Safety, etc. A full list of our evidence is available on our website. And also recently we published a book in collaboration with the European Observatory on Health Systems and Policies, in which we put some policy context to our research findings. We explain how nursing education is organized within these countries and how nursing policies take place within these countries. You see that we have 14 countries. In this study we also have Latvia, for example. So we included some new countries with very different policies than the countries involved in RM forecast. Now, I've been involved in quite a lot of research since RM forecast, but what still strikes me the most today is the amount of variability that we see in the measures in our study. The primary measures in our study have been patient-to-nurse ratios, have been nurse education levels, and have been nursing work environment quality. If we look, for example, at nurse staffing ratios, we see huge variability. We see variability across countries, but we also see variability within countries. What you see here, for example, is the number of patients per nurse. And I think we can all say, well, the less the better. So on the left, you have the US with 5.3 patients per nurse on average. On the right, you have countries like Germany, Belgium, which are in the range of 10 to even more patients per nurse. But as you can see, for example, in Belgium, these data are for 2009, but I will provide you with an update later. In Belgium, we have variability between, at the hospital level, from 6 patients per nurse to 16. So that's what I say when variability is what is key here. So variability is what makes a statistician happy, but for a policymaker, this is quite a nightmare. We also see this variability in the practice environment, the quality of nurses' work. What is that? It is about staffing adequacy, it is about participation in hospital affairs, it's about managerial support, nurse-physician relations, and promotion for care quality. I don't know how many of you are familiar with the magnet concepts, magnet hospitals in the US. I see many people nodding. So these are traditionally the forces of magnetism that we also measured in Europe using the same instruments used in the US. What we see here is again this huge variation between countries, and we also see it within countries, believe me. What we note here was that if we compare we had about 500 hospitals in Europe that participated in these 12 countries. If we look at their average scores on the work environment, just a few of these 500 hospitals even reach the standard of the average magnet hospital. So European hospitals really perform quite poor on work environment measures. Very interesting to policymakers as well is that, as you may know, several countries maintain 2 educational pathways towards nursing. And then I'm not even talking about the various pathways for assistant nursing or the various names that has across Europe. What we found was, I think there is a problem with the slide. Is it in PowerPoint?
Yeah.
Yes.
Okay, what you should see here. Yeah, but it's missing. What you should see here is well that we have, for example, Norway and Spain, where the full workforce of nurses is educated to the bachelor level. In Germany this is 0%, because at that time they didn't have a bachelor's degree level. And for example, in my own country, Belgium, about half of the nurses have a bachelor degree, and the other half has a diploma degree, a vocational training. It's very different across countries. You know that there are this kind of Bologna agreements, etc. But still, if we look at the quality of the nursing education, it's very divergent across countries. And also here, again, you can see, this is the minimum and maximum at the hospital level. By the way, these were all acute care hospitals and all surgical and medical nursing wards. At the hospital level, this varied in Belgium, for example, from 25% to 85% bachelor educated nurses. So again, huge variability. It's less visually attractive, but here we also see that there was variability in the amount of care that nurses leave undone. So what we ask nurses is, during the last shift you worked, were the following care activities necessary, but did you lack the time to complete them? Concretely, that means that about 4 in 5 nurses in Germany say that comforting or talking with patients was a necessary activity during their last shift, but they couldn't do so because they lacked the time to do that. There are many examples like that that are quite heartbreaking, I think. Now, I make a little bit jump forward. So on the one hand, we have this variability in our explanatory variables, nurse staffing, nurse work environment, qualification, and also this missed care. On the other hand, we also have variability in the outcomes. For example, what you see here is variability in patient mortality. We collected information on patient mortality from 300 hospitals in 9 European countries. What you see here on the horizontal axis is each time a hospital. Okay? So each bar is one hospital. On the y-axis, you see the percent of patients that died. To be clear again, here I'm talking about 42 surgical DRGs that we mapped across these countries. So I'm talking about similar types of patients. What you can see here is that the crude mortality rate varies from 0% in one hospital to just over 7% in another hospital. What you also see is that, well, it's difficult to see, but I'm sure you will get the slides afterwards. What you also see is that each country is presented by a color. And for example, in Belgium, it's not a secret anymore, we're 10 years later, Walter. So in Belgium, it varied from 0.3% to 3%. There's about a 10-fold difference in patient mortality, depending on the hospital. Of course, there are certain patient characteristics that we need to take into account when doing this research, and also these data we had. So this was a huge effort. It took us about 2 years to collect these minimum hospital data that also have very different structures, very different coding mechanisms, ICD-9, ICD-10 across countries. But I think we managed to do that quite well. So now the question is, on the one hand, we have variability in the nursing workforce aspects. On the other hand, we have variability in the outcomes. And here I focus on patient mortality because I was given a limited amount of time to talk about this research, and it's the most eye-catching outcome in our study. But we also see this variability in burnout, job dissatisfaction, intention to leave, etc. So the question is, do these types of variability now correlate in some way? What we indeed see is that if we look to the effect of nurse staffing on patient mortality, we found that if we correct for type of hospital, whether it's a big hospital, whether it's a university hospital, whether it's a high technology hospital, if we correct for different patient characteristics, age, gender, admission type of surgery, comorbidities, Charlson comorbidity, etc. If we do all these corrections, then we find that the more patients nurses have to take care for, the more likely patients are about to die during their hospital stay. What we also see is that the higher the percentage of bachelor-educated nurses, the less likely patients die. There are some important methodological shortcomings to this work, which is the cross-sectional nature, etc. You can imagine that it was not possible for us at that time to do an intervention study, increasing nurse staffing in one hospital, decreasing it in another hospital, for example. But still, what is important about these associations is that across time and across place, these associations have been reported consistently by researchers, independently from each other. What we also see, and it's very important, I think, for workforce planning, there is a lot of attention going to skill mix. Skill mix has very different operational definitions, but here we had skill mix as the percentage of nurses, registered nurses, meaning nurses having an official nursing degree, to the total proportion of care personnel. And what we found was that the lower the percentage or the proportion of nurses to the total number of care personnel, not including physicians, I'm talking about bedside care personnel, the higher that proportion, or the lower the proportion of nurses, the higher was patient mortality. Now this is quite important because what we saw in the UK at the time we were about to publish that work was that policymakers in the UK, when they talk about staffing ratios, they collapse together nurses, nurse assistants and various other assisting personnel, which is completely wrong, we believe. So what this paper in fact shows is that the net added value of healthcare assistance is quite unclear, or even it has a detrimental effect on outcomes. And here I highlighted the outcome of patient mortality, but all the other outcomes we ever studied in our forecast are also included here. Again, healthcare worker outcomes, again also patient experiences with care. All these outcomes were worse when there was a lower percentage of nurses in the workforce. About missed care then, so like I said, missed care, it's the care left undone by nurses. Also there was a direct effect on patient mortality. The more of the tasks, the 13 tasks that we measured, that nurses can indicate that they leave undone, the higher that percentage of tasks, the more likely we found that patients died within these hospitals, these 300 hospitals in our study. And it was, if we went to the full statistical modeling, I won't bother you with that, but it was a clear mediator within this relationship of staffing and outcomes. So what it really means is that if nurses have more patients to take care for, they are less likely to complete the necessary care they want to provide, and the more likely patients are about to die. So I know it sounds all quite logic, I hope, but at that time when we published the study, this association was never really unraveled like we did before. What we also saw was that, like I said, we included 12 countries within our forecast, that various of these countries involved, like Scotland, Ireland and other countries, they started really working with our research findings. They saw the policy window that our findings created. Wales, for example, it wasn't even involved in our study, but they took our study findings to heart and really created policy from that. You see that they have Nurse Staffing Levels Act in 2016. Other countries that were involved in the study didn't really saw the policy window, it appears. So very briefly then, some recent additions to the evidence, because our forecast, it's already 10 years ago, the data collection, of course. What we recently did in Belgium was to do this exact same survey again. But this time what we saw was that almost all hospitals in Belgium wanted to participate to our study. So it really means that this topic of nurse staffing and the effect on quality of care is a really hot topic. Over 5,000 nurses participated, and what we saw was that between 2009, which was our forecast, and 2019, we saw a decrease, a shift to the left, and on the x-axis is the patient-to-nurse ratio. We saw a decrease in the number of patients by nurse, so which is positive, right? We saw this decrease both in the morning shift, in day shifts, and in night shifts. So there was a positive evolution, but if you look at these graphs, the variability stays the same. Now, I hope this really strikes you, because it means that during night shifts, Belgian nurses at the time of our forecast had to take care for more than 20 patients by themselves. There has been a positive evolution, but it's still 18 nurses per patient. In some countries, in some states within countries, the number of patients to nurse is fixed at any time of the day. So it means morning, day, night, it doesn't matter. The ratio is fixed. As you can see, this is not at all the case in Belgium. What we still saw was that, it's too difficult to read from that far, but what we still saw was that our nursing work environments have remained the same, or even to some, in several hospitals, deteriorated. So we have by far not reached the magnet level of quality of work environments. What we saw was that blue is 2009 and then gray I think is 2019. We saw an increase in the number of missed care, statistically significant and also clinically very relevant. Also very important for health workforce planning, and I come to that also in the next slide, is that we see that nurses perform a lot of tasks that are in fact under their skill level, that could be distributed to lower qualified personnel. But again, look at the variation. For example, we see that in one hospital, about 40% of nurses say that they sometimes or often have to transport patients. In another hospital, it's up to 100%. So also hospitals are very differently organized in their nursing care. Michelle gave me 1 minute, so I'll focus on what's most important. What we also concluded from this study is that we need about annually 160 million to move from our current staffing ratios, which average to 10.6 patients per nurse, to 8.1 to 8 patients per nurse. Sorry. So if you want to make this positive shift from the current situation to what we really want, we need 160 million on an annual basis, just for these services, by the way. Okay. A very last remark on that is that 8:1 is not a safe patient ratio. Please, if you start working on this in later sessions, lose the 8:1. 8:1 is just a ratio that we picked in terms of the literature. Also in England, NICE has provided some guidance to that, but it's not a safe ratio. Everything above 8 patients to one nurse is really bad. But it doesn't mean safe. If we want to move to safe ratios, let's say 6:1, we need to triple that amount of money. And as long as Michelle doesn't really interrupt me.
15 seconds, I guess.
So, with what did I want to I think that's a good conclusion, but what you also need to take into account, and this is research from the UK, is that complete association between that scope of practice, leaving care undone, performing tasks below skill level, and the role of assistive personnel there. What this paper shows, for example, on the right by Needleman, which was in the UK, and on the left is the UK, and on the right is the US, was that also assistive personnel has a direct effect on patient mortality. So you need to, when you do the forecasting, focus on both the nurses, registered nurses, as well as the assistive personnel. Thank you.
Thank you for the speech, Luc. So I guess we can now switch on first from computer, then from speaker. Here is the tool.
Okay.
This has I will ask them after the 15-minute speech by Paul from the Imperial College. So, of course, if the presentation shows on screen.
Okay, so, well, I'll start talking and hopefully the slides will come up. Thank you very much for inviting me here. It is a joy and a pleasure. And I guess I'm going to talk mainly about my work because that's the work I know best. And the work around the weekend effect and the junior doctor changeover really comes from my own experience, I suppose, as a junior doctor. I remember being parachuted on my first day of work into a hospital with no idea how the mechanisms worked, how to order bloods or anything like that. And I remember working at weekends as well and being told not to order certain tests because the laboratory staff didn't work weekends, or we'd have to call someone in. And I remember waiting long periods of times for x-rays and scans and things at the weekend because staff weren't there. So this comes from my own personal experience. When you look at the literature, the seminal paper on the weekend effect is a paper by Bell, a New England Journal of Medicine paper, which was published in 2001. And this looked at, I think, 3 or 4 million patients in Canada and found an overall effect. If you look at emergency patients admitted at the weekend compared to patients admitted during the week, you find around about a 10% increase in the risk of death. And I think we might be coming... Aha! We have some slides. Outstanding. So, oh, no. So that's good because... here we go. Okay, so... and if I just press the forward... Yes, so this is the Chaim-Bell paper that I was talking about, and they found around about a 10% increase in the odds of death for emergency patients admitted at the weekend compared to patients admitted during the weekday. And they looked at a whole range of different diagnoses and found a strong effect in many of the individual diagnoses that they looked at, including abdominal aortic aneurysm, around about 28% higher odds of death, pulmonary embolism, stroke, and a whole range of conditions. And they found that none of the specific conditions that they looked at had significantly lower mortality rates at the weekend. So I decided back over 10 years ago now to see if we could replicate the methodology that Chaim-Bell used for his Canadian study in the UK. So I happened to be working in a unit where I had access to large amounts of administrative health data for patients admitted in England. And we published this paper in what is now BMJ Quality and Safety, and it was called something else when we published it. And we looked at all emergency admissions in England for a 1-year period. And again, like Bell's paper, we looked at a range of different diagnoses. We made some adjustment for age, for sex, for socioeconomic deprivation, for comorbidity, and diagnosis when we were looking at the overall odds of death. And we looked at patients admitted at the weekend compared to patients admitted during the week. And we looked at 4 million admissions with over 200,000 deaths. And we found a slightly increased risk of death for patients admitted at the weekend compared to weekday admissions, an overall odds ratio of 1.1, so around about a 10% higher odds of death in those patients. So very similar results to Chaim-Bell's. And again, we looked at some 50 diagnosis groups, and 17 of those had a very significantly higher odds of death, including things like stroke and heart attack. Now, when we tried to publish this, we initially sent it to the BMJ, and it was rejected. Now, I'm used to having papers rejected from the British Medical Journal, as indeed most academics are. But the reason they gave was that, and this is the email that they sent me, the effect of weekend admission and mortality is already well documented, and there is no reason to expect the UK would necessarily differ from the North American setting. So there was no surprise amongst academics and clinicians in the British Medical Journal that the weekend effect existed. And in the end, we published in BMJ Quality and Safety. So that was interesting in itself. Now, there were some limitations with our paper. There were fewer admissions at the weekend, and we thought perhaps that might represent perhaps a different case mix. And although we tried to adjust for case mix, perhaps we couldn't completely adjust for case mix. And we wanted to look at a different group of patients. So we looked at elective surgery, so planned surgery. Now, you may wave your arms and say, but hang on a minute, planned surgery at the weekend is almost non-existent in many countries, and certainly not very common in the UK. It makes up only about 1 or 2% of planned surgery. But our hypothesis was that patients who had their surgery at the end of the week on a Friday, who had their post-operative care at the weekend, might have worse outcomes. And we predicted less variability from Monday to Friday for planned surgery. So we used the same source of data, administrative hospital data from England. We looked at elective surgery over a 3-year period, and we looked at surgery that was likely to be carried out in the operating theatre. So we excluded minor procedures and day cases. We were able to look at post-operative, 30-day post-operative deaths in this analysis, so we were able to look at patients who were discharged home and then died within 30 days, which we weren't able to look at with the previous work. And we adjusted for a whole range of things, including a proxy for the complexity of the surgery. So we ranked each of the surgical procedures and took quintiles in terms of their mortality rate. So we tried to adjust to some extent for the complexity of surgery. And we looked at 4 million operations, 27,000 deaths. So the mortality rate from elective surgery, thankfully, is much, much lower than emergency admissions. And the best thing to do is to show you this graph here. So we compared mortality by day of procedure to the Monday rate. And as you can see, as your operation approached the weekend, your risk of, or your odds of death went up such that on a Friday you had a 40% higher odds of death than if you had had that same procedure on a Monday. And the weekend, although we didn't make very much of the weekend because it's a different mix of procedures, but actually in the UK it tends to be more routine procedures, things like hip replacements, knee replacements and things. Your risk of death was around about 80% higher. Now that's an 80% higher of a pretty small risk, but significant nonetheless. We had a lot of press and media response around this, and some clinicians were interested in this. This was a rapid response on the British Medical Journal from a junior doctor who said maybe the reason for this is the practice of drastically reducing the number of doctors, in particular junior doctors, working out of hours and weekends. A first-year junior doctor may cover a number of wards, as many as 60 to 100 patients, and their immediate senior may cover twice that number, and so on up the ladder. So even at that time, it was recognised by the workforce, or some of the workforce, that this was a problem. So our next paper, our next study, we wanted to look at the process of care as well as outcomes. And we thought, the data within administrative data, or the information within administrative data, is a little bit limited on the delivery of care and the process of care. It's better for outcomes. But we do have some information, and for this we decided to look at stroke, and this is our rather poor taste title here, Dying for the Weekend. And we looked at stroke patients. We looked at something like 90,000 stroke admissions. And we used a number of indicators within the data to look at process of care. And probably the best thing to do is to look at the table here. And so we showed that stroke patients admitted at the weekend were less likely to get a scan on the same day of admission. They were less likely to get thrombolysis. They were more likely to have an aspiration pneumonia recorded. They were more likely to die within 7 days. They were less likely to be discharged to their usual place of residence, so that's a sort of a proxy for a good outcome. And the only indicator that wasn't significant was a readmission rate. Perhaps that's because they all died and they therefore couldn't be readmitted. So that was interesting. Our next paper which was really our last sort of paper looking at the data itself. No, actually, it wasn't our last paper because we got a few more. But this paper looked at obstetric care, and we thought obstetric care, you can't necessarily choose when to go into labour, and we do know when planned deliveries occur. That's pretty well documented on the data. So we thought obstetric care would be a good next condition to look at. And so we looked at 2 years of births in English NHS hospitals. We looked at 1.3 million deliveries, and we looked at a range of maternal and perinatal outcomes, weekend versus weekday, and we adjusted for a whole range of variables, including whether the delivery was planned, whether it was caesarean, those sorts of things. And so these are the baby indicators, the maternal indicators. So for mothers who delivered at the weekend, they were more likely to get an infection. That was the only one of the three indicators that was significantly different. But for babies, they had a higher risk of death, higher risk of injury, and a borderline increase in their readmission rate. Unfortunately, when we published that paper, it came out about 2 days before junior doctors were marching to go on strike over a contract dispute. So the Secretary of State was trying to impose a contract to encourage, I suppose, the hospitals to be able to have more junior doctors over the weekend. So there was a huge row about this. Junior doctors did go on strike. And as a result, we had a tsunami of responses on the British Medical Journal, mainly by angry junior doctors, accusing us of working for the Secretary of State and things like that. Of course, nothing could be further from the truth. But it was very, very troubling, and my fellow researcher, Will Palmer, who was the lead author on this, who was a PhD student, was subjected to trolls and all sorts of nasty things from junior doctors. I suppose what annoyed me was that our study wasn't the first study to look at birth outcomes. There was a BMJ paper published a couple of years before this paper in Scotland, which found a 30% increase in the odds of death in babies delivered at the weekend, and looked at the causes of that, which was likely a large proportion was anoxia. So I've been given 1 minute, so I'm going to talk on junior doctor changeover. I mentioned when I first became a junior doctor, and this is the practice across many countries in Europe and in the States. In the States, it's called the July phenomenon. I decided to look at mortality in patients admitted on the day of the junior doctor changeover on the first Wednesday in August compared to the previous week. It's quite difficult to look at because obviously some patients are in over 7 days and they can overlap with this first Wednesday in August, which is when the changeover happens. So we only looked at 7 days of outcomes. So I looked at 7-day mortality, so there was no overlap there. And I only looked at 2 days of admission, this first Wednesday in August and the previous Wednesday. And I looked at that for 9 years. And we found overall a borderline, after adjusting for case mix, a borderline sort of 6% increase in the risk of death in patients admitted on the changeover compared to those patients who were admitted the week before. And it was a slightly bigger effect in medical patients. We didn't see the effect in surgical patients. And again, huge publicity, media coverage, but I suppose we have to remember from our study, we're looking at fairly small numbers just on single days. So our figures equate to just 11 extra deaths a year. We only looked at the first day of the changeover, but how long does the effect last for? And we have done other work since then. There are, if you look at the evidence, there are hundreds of papers out there. This is an analysis we looked on UK studies alone on weekend on the weekend effect and a big overall effect. But if you are interested in our further work, looking at follow-up and interventions and things, then do come to my workshop, where I will present more interesting, fascinating data on even more recent work and some unpublished updates as well. Okay, that's me.
Thank you. It's true that Paul has twice the amount of slides for his next workshop. So for those interested. So thank you for that. We have lost some 10 minutes with computers and a few extra words from Walter. So we'll take this time. It's a workshop we need to discuss. So we'll take these 10 minutes more. We have some 20 minutes for interaction. I'm very delighted to have heard these two presentations, because from planning we had enough in my career about numbers and budget, and now I think these two presentations have addressed health output and, let's name it, mortality, which is quite different from addressing national numbers and national figures. So now, first of all, let's have an interaction with the room. And I would like to hear you, not only questions, but also comments. Please be allowed to state quotes if you, of course, try to stay in a reasonable timing. Who would like to start quoting the different, the two presentations and the scientific input?
Sandra Buttigieg.
This microphone is for recording. It's not for,
okay,
you
sorry.
have to speak loud.
Okay,
That's right.
that's fine. Sandra Buttigieg, I come from Malta. I'm very much interested in this research with regard to both the aspect of health workforce planning and quality of care patient safety. So far, a few comments to both speakers. Very interesting, a lot of evidence, which is important. With regard to the first speaker, there is the model that we've seen mostly as direct main effects between, if I just go back to the main effects between nurse staffing and work environment with as the outcome variables, patient care quality and safety, etc. So I suppose that the next level, which also he mentioned one mediator as he went along, there are a number of moderators and mediators in between the independent variables and the dependent variables. For example, research which I and some colleagues did was relating work environment with patient safety and mediated by burnout, something that's of interest to the room here. We also did, however, that was cross-sectional, and that is another comment I want to make, that most of the research that we have is cross-sectional, and of course in this line of research is very important, time is very important as a construct. So longitudinal studies are important, but there is a dearth of such studies because of various reasons. And another one is also that although you have a work environment that we published as well, it's open access, where you have all the policies, all the guidelines in place, everything is in place as regards the usual protocols. If there is no buy-in by the leaders and management of that unit on patient safety as a priority, you can, we have a saying in Maltese, you can have the water dancing, because you will not get the required patient safety outcomes that you need. So although at the executive level, the hospital may say they have a team on patient safety, etc., if at the front line or, you know, there is no direct management or leadership that have patient safety as a priority, then that is a problem. With regard to the second speaker, again, very interesting. I think the next step is to look at combining professions together, because professions do not work in silos. So I would go the next level. I would like to see some evidence with regard to teams of professionals at any one point in time, because that is the interesting, and that is what approximates the real world. Thank you. Sorry for being...
It's okay. You're home. Any other quotes and comments to address to the room? Yes.
First Thomas Kearns from Dublin. Just very briefly, particularly in relation to the Ireland forecast, I mean, Ireland were partners in that. To me, there is a real significant body of evidence that collates all these variables together, and yet, globally, it doesn't seem to make a snidget of impact on policy decision-making in terms of translating that into reality. And I think part of the reason for that is that we're not putting an economic analysis on the impact of all of these things. So I mean, it's wonderful research, and you are bringing research, practice, policy, all of those things together in patient safety, all of those key variables together. I think the thing we need to now strengthen to pull the circle together is economic impact. That's my opinion.
Maybe a third quote or comment before asking the speakers to react a little bit. Andrew? Sorry for the recording.
It's Andrew Schwer. Dr. Aylin, just a quick question. I mean, are there staff ratios agreed here in Belgium, where you were quoting 1:8 in nursing, etc., and agreed with the unions, for example, with the workers' representatives? And what are the legal implications if these ratios are not reached? I mean, because it all depends on the supply, right? So perhaps at one day you can make it 1:8 or 1:6, and the other time you can only make it 1:10.
Thank you. So we have both questions on the policy impact, how to make it move, and what to research further. So maybe starting with Luc, you got a microphone. Go ahead, maybe on the economic impact, if you like.
I fully agree with the comment. It is true that this type of additional dimension to this research is quite neglected. I think it's also a very difficult dimension to investigate. Jack Needleman has published some work on that, including in the New England Journal of Medicine. But all in all, I think if you look at the business aspect of this work, it's very difficult to disentangle to whom the benefits accrue, to whom they apply. Are we talking about a real business case, or is it an economic case? We have a lot of perverse effects going on in hospitals that really don't, indeed, like you say, encourage hospital managers to really start increasing ratios. So what we are quite forced to is to rely on this kind of natural experiments. And for example, I was talking about the 100 million additional budget in Belgium that we need to move to 8:1 ratio, but in fact we have a 400 million additional budget that was agreed upon by Parliament. At the same time, it was not really because of the study findings. Our study was going on, and then at the same time the Parliament decided to do that without any evidence, except for the RM forecast evidence, of course. So now we have this kind of natural experiment, and we will see what the impact is on that. But I fully agree with your statement.
Okay, Paul, could you address the questions on what we need to further research and how and which methodic to apply if we have the opportunity?
I might do. And I wasn't just checking my Facebook account here, I was writing down some of the questions. So I will just address your question around teams. And I deliberately didn't present any of our evidence where we actually looked at the workforce. I was just looking at temporal differences. The workforce obviously is implied from that. But I will present some work on reorganisation of healthcare services and perhaps how that may have had an impact in the work group. In terms of how to get impact, we had huge impact from our papers that we published through press and media coverage. I mean, although it wasn't news to academics and doctors that there was a weekend effect, it was certainly news to the general public around these differences in mortality. And as a result, I think mainly of the media coverage, the government were forced to act. So we had 7-day working policies. We had, for the junior doctor changeover, there was an introduction of shadowing. So medical students who are about to, or qualified medical students who are about to take over the job were forced to spend 4 days shadowing the outgoing junior doctor. And I'll present some work at the workshop around some of our early analysis to see whether that's made an impact. But what we did find was that it can work both ways. And as soon as our work became wrapped up in an industrial dispute, the sort of the sway of public opinion and certainly professional opinion seemed to sway. And not that I'm bitter about this sort of thing, but after the industrial dispute, there was a plethora of papers coming out of single hospitals within the UK disproving or trying to disprove the weekend effect. Most of these studies were far too small to show an effect anyway. They wouldn't have been able to show a weekend effect if it had come up and slapped them in the face. But now the weekend effect is not called the weekend effect in the UK. It's now called the so-called weekend effect. And I don't know whether this is reflected in other parts of the world, but certainly it's controversial in the UK because of, I think, resulting from an industrial dispute and people wanting to disprove this effect. And it's interesting to see how science works or doesn't work in this circumstances once it's wrapped up in politics. I can rant about that for hours and hours, but I won't.
We have the whole dinner tonight.
Right. I'll bring my slides.
Right. A second round of comments and quotes and questions.
Thank you. John Delamere is my name, representing HOSPEAM and the Health Service Executive in Ireland. I'm aware of some of these studies, as my colleague Tom here has said. I was just wondering, an issue, I suppose, is for Luc in terms of his study. Did the issue of the stabilisation of the workforce come into it? For example, I think it's well known in European countries there's a major difficulty in recruiting and retaining nurses at the present time. Hence, there is quite a high dependence on nurses coming in through employment agencies who may be in one unit for 2 days and move again and whatever. The impact of that versus circumstances where you would have a stable workforce, where you have people who have an ongoing familiarity with their unit and with their patients. Did that come into it, or is it estimated that that would have some bit of an effect on better outcomes and less adverse incidents, etc.?
Thank you. Any other people willing to add? No, too early in the morning. I got some additional questions for you, of course. On the research side, I would like to be advised by both of you if what the research you did in the hospital sector could be extrapolated or turned alternatively to address elderly care and the primary care, because this is another setting which obviously in most of the European country is mentioned as underfinanced. And various countries try to set a ratio patient per GP or a set of nurse, assistant nurse and psychology care in elderly care, also with a normative effect or not. So the issue is obviously the same with maybe as many adverse effects. So would you maybe share the questions? And I would ask the first Paul to answer your Irish colleague first.
Yes, continuity of care. Interesting. I mean, from my research, I don't have that sort of resolution of data around staffing. In fact, we have very little data on staffing. But I will make a comment about the sort of engineering incentives and climates for that sort of thing. I know in the UK, speaking to some nursing colleagues, there are some hospitals which ban senior nurses working at the weekend because they're too expensive to employ. So there is just a flat ban on very senior nurses coming into the hospital at the weekend, which seems a crazy idea. That's essentially what the Secretary of State was trying to change around junior doctors, to try and get more to create an economic climate which encourages more junior doctors to work at the weekend, but didn't even consider the nursing climate, which I think from Walter's evidence is possibly more important than the doctor thing. But I think continuity of care is something that would be super good to look at. But in terms of big numbers and my work, it is very, very difficult. And in terms of extending research to primary care, again. Well, in primary care in the UK is interesting because sort of out-of-hours care seems to have reduced and fallen to many agencies, and therefore is again difficult to look at with data. And in the UK, although primary care are in many ways very much ahead of the game in terms of electronic data, they've had electronic record systems for decades. There is no central repository of these data. So again, it's quite difficult to look at. But you can see the impact potentially, or one of the explanatory variables around hospital care is that because primary care is not so accessible at the weekend, that patients are coming into hospital. And that has been put forward as one of the potential explainers of the weekend effect. It might explain some of it. I don't think it explains all of it, but it's certainly something to look at.
Maybe look adding on the extension possibility to elderly care.
Maybe, yeah, okay. Maybe just first to your question, I think continuity of care is, it's actually an item that we measure using our work environment scale and which performs quite poorly across all countries. So continuity of care is a concern among nurses themselves. The solutions towards continuity of care quite differ across countries. For example, I think in the UK you have this kind of bank nurses, and in Ireland also. What we also saw in our forecast was that the proportion of foreign trained nurses was quite different. I think in Ireland I remember seeing a lot of Philippine nurses, Indian nurses, etc. And what was interesting about that was that we saw that these nurses come here, and I'm not talking about their level of education, but what we see is that these nurses perform relatively more non-nursing tasks compared to the natively trained nurses. So there is a question of efficiency there going on if you use this kind of other nurses outside your own healthcare system, maybe. I think there was also a question from you regarding the ratios and whether there is some kind of legislation in Belgium. There is legislation. I think, let's say it's outdated, and it also doesn't really specifically define patient-to-nurse ratios. It's more on a ward level basis. and there are some mechanisms to correct for intensity of nursing care. But all in all, I think these ratios or the ratios that can be derived from that are far from safe ratios or evidence-based safe ratios. So we have a long way ahead of us to work on that. Regarding the translation to other sectors, it's difficult for us. The reason that we always focused on hospitals was because mortality is quite high in these hospitals, and it's something that you need to explain variability in that. I think our colleagues from Switzerland translated the research to nursing homes, and they found quite similar findings. Primary care, etc., is much less research.
Okay, due to time constraints, I will ask a last quick questions to both of you. The room is filled with either health planning professionals or policymakers. So it's time to address them in a few words. One advice on how to proceed further, translating your study in their own work. How would you advise them in a quick sentence? Yeah, you may start. You got still have a micro. Yeah, sorry. It's early for me too.
So I think you need to be ambitious. I've been a member of the Belgian planning committee for a few years myself. And I think a lot of data is available. I think it's now the question to, if we're talking about nursing especially, to have measures of staffing available on a regular basis. We can't do this kind of survey research continuously. What we now use is nurses as informants of their care. But in fact, I think it's better to move from this kind of volume-based patient-to-nurse ratios to really multifactorial nurse-to-patient ratios that also capture the acuity of patient care, which was much less well discussed in the RM forecast work. And like I also said during one of the slides, I think it would be good not to mix all kind of measures and to come up with some kind of care worker to patient ratio, but really specify it by profession and see how you can move forward for each profession.
And Paul?
Oh, blimey. Okay. So I would say look at the evidence. And be critical of the evidence, and don't just take my word for it, because obviously I have gone down a particular track, and recognise that there may be other agendas behind some of the research. And also, when you're translating or attempting to translate some of the evidence, be aware of the politics, of industrial relations, because if you start changing shift patterns and things, workers don't like change in general. In terms of research, of course, I want to do more research. I never want to touch the weekend effect again, I can tell you that. But I would love to see more data on staffing, so high-resolution data on staffing. At the moment, we have very little data available to us. And with the introduction of e-rostering, that should perhaps be more easy to get hold of in some point. And then I'd also say, in terms of research, that some of these questions can't be got at through just quantitative analysis, and I'm not an expert sorry, they can't be got at in quantitative analysis. I'm not an expert in qualitative analysis, but you need that as well. You need to look at some of the reasons and some of the much more interesting stuff that you can get at with qualitative research, which can potentially explain some of the quantitative results that we've found. It probably doesn't answer your question. But
every advice is good to take. So sure, half of them will go back to the country to say, this Paul needs funding for his studies. But so we are 15 minutes later than foreseen. Sorry for that. It's not yet a big deal. So let's take these 15 minutes coffee break as designed. You need to stretch legs. Some of you were really early here.
Good morning, everybody. My name is Bruyneel. I'm a
the subject is really straightforward. The impact on mental health issue and well-being of health workforce on the productivity rate and patient safety. The engineer in me already sees a mathematic model, but that's not about it. We're not yet there. And it's still a very acute element, as in the daily management of healthcare facilities. We sometimes hear a lot of stories related to turnover, with different reasons for the turnover. Mental health issue is one of these elements. And we also know that there is a snowball effect sometimes that can lead to the impossibility to manage a healthcare facility, leading, of course, to adverse events for the patient. So, Maria, thank you for this. Give me a few seconds to switch from slides and launch the timer. And then I'll give you this. This is for the recording purpose. It's not really for talking to the room, but please. Give me a few seconds. That's already on. This one. Not yet on screen. No.
No. It is on screen. Yeah.
Right. And is it the first slide? Yes.
Yeah.
Last check. Is the remote controller working? Yes. Still.
It does.
Ah, yes. That's fine. Yes. You're all set. The floor is yours.
Right. So thank you for the invitation to present in this workshop. I'm delighted to present some findings about the association between the well-being of health professionals, or otherwise most commonly known as burnout, with patient safety as well as productivity in healthcare professionals. Well, what is patient safety? There are different definitions, but we could say that patient safety is the absence of preventable patient harm. So it's coordinated efforts to prevent harm for patients, and especially this type of harm that can actually be prevented through intervention and amelioration of the process of providing care. Patient safety is a critical dimension of universal health coverage. It's one of the top priorities of the WHO. And since the last 20 years, there have been many efforts in many countries for improving patient safety. Up to date, the main focus has been on improving systems, for example, trying to make the systems more standardized, more using health records, or also trying to identify patients who are at risk. For example, patients who have multimorbidity, patients who have a combination of conditions that are more likely for them to experience harm. But very little has been done in identifying who the health professionals who are more likely to make errors, not because it's their fault, but because of the context and their working environment. Throughout all the patient safety agendas, as well as taxonomies, it's clear that the working environment is has an important association with the working environment, with the patient safety. And in order to improve patient safety, we have to have a healthy working environment. Although there have been many studies and many over the years about the prevalence and severity and nature of patient harm, there were still many disagreements because of the methodologies in the studies. What we did recently, about a year ago, we did a large meta-analysis of the prevalence, nature, and severity of patient harm across the medical care settings. We identified that 1 in 10 patients experience harm while they're in the process of their health care, independent of setting. And 50% of this harm is actually preventable. So 1 in 20 patients who are receiving care are likely to receive experience harm, which actually can be prevented by putting the right measures and improvement exercises in place. Major causes of harm were related to medication errors, related to other therapeutic procedures, not necessarily medication, and also invasive clinical procedures. It was more, up to 10% of this harm was actually severe and could lead to death for patients or severe disability, severe and permanent disability. We found that preventable harm is highly likely in intensive care and surgery as well, but we found very little evidence in other settings such as primary care, mental health care, community care. Overall, I like this diagram which has been developed by colleagues, which show the association between organizational culture in hospitals with the performance of hospitals. And it looks like there is a direct link, and should be a direct link between the organizational culture and then the performance of hospitals. However, the well-being of doctors can be a mediator in this relationship. So if you can see, there is two ways. There is a direct effect between organizational culture and performance in hospitals, but there is also an indirect path, which is through the well-being of health professionals, and particularly through burnout, because burnout then is associated with negative outcomes for health professionals, negative patient outcomes, which in turn lead to lower performance in healthcare systems. In terms of burnout, I mean, this is a common concept nowadays. There is a lot of literature, a lot of, but basically it's quite often in the news about talking about burnout in doctors and other health professionals. Well, the concept of burnout is quite, it's a few decades in the literature, and the most common way of conceptualizing burnout is by thinking of three manifestations, which has been developed mainly by Maslach. And these are first exhaustion, so health professionals feel exhausted, can feel exhausted cognitively, emotionally, also physically exhausted. The second component is about depersonalization or cynicism. This means that health professionals gradually distance themselves from their healthcare organization and the patients. They don't feel connected anymore. They don't feel they don't feel that they don't value the relationships with their colleagues and patients. And finally, there is a sense of low self-efficacy. So they feel that their work doesn't make any much difference, and they have less professional accomplishment. It's quite scary that burnout nowadays has been described almost like an epidemic in health professionals. So up to 50% of health professionals are experiencing at least one sign of burnout, and this findings is not something that has been found only once. The past 5 years that burnout is measured more frequently, almost all the surveys have shown similar findings. And then what are the main drivers of burnout? What the physicians report and what the studies find is that is mainly driven by the working environment. So is focused on is the result of a toxic working environment, excessive workload, loss of organizational support. So health professionals feel that they're not really supported by the working environment. They've got problems with their work-life integration and balance. So many doctors doctors and health professionals focus mostly on their professional career, and they feel that it's difficult to integrate their personal life within the tight timelines that they have as part of their work. Another issue which is important as well is loss of autonomy and control over their work. They feel less valued and less likely, and they feel like the system is actually controlling all their work, and they leave them very little sense of autonomy and control and the ability to actually work independently within the system. And finally, there is a loss of, they feel a loss of values and control over their meaning in their work. And what are the main consequences of burnout? Well, the consequences of burnout range from personal consequences. So health professionals are more likely to feel depressed. There is a high association between burnout and depression. Actually, there is also there is a disagreement in the literature. There is also a debate in the literature, let's say, that burnout and depression are highly correlated and could be almost similar, although I don't particularly agree, because burnout looks like it is mostly caused by environmental factors and organizational factors, while depression is more an individual diagnosis, let's say. In terms of personal consequences, health professionals are more likely to be involved in accidents, to experience suicidal ideation. Actually, suicide rates in health professionals are actually the highest across any other health professional groups. And they're even more likely to die by road accidents. In terms of patient outcomes, is also very important because it has been linked with increased medical errors and reduced professionalism, so they're more likely to have complaints by patients. And then in terms of organizational outcomes, because I consider them more like organizational outcomes, burnout in health professionals is associated with high levels of turnover and also reduced productivity. I mean, there has been a lot of literature around the association between burnout, patient safety, professionalism, and patient satisfaction. But to be honest, until a couple of years ago, this literature was mainly narrative, and there were no quantitative evidence, at least across the studies that have been published, on the association between burnout and patient safety, professionalism, and patient satisfaction. So we did another paper which synthesized the literature quantitatively, and we had one main question, which was, is burnout associated with lower quality of patient care? Actually, this meta-analysis focused on doctors, but the findings are the same across all health professionals, so it doesn't make any difference. Actually, only recently another paper came out which looked at the association between burnout and patient safety across all health professionals, and they have found exactly the same findings. So we looked at whether burnout is associated with patient safety incidents, whether it is associated with suboptimal patient care outcomes resulting from low professionalism. And then we looked at whether it is associated with lower patient satisfaction as well. Our aim was to understand to obtain a more holistic understanding of the impact of burnout in healthcare service delivery. An association between burnout and the performance of healthcare systems could actually lead to, could make the stronger case for organization-wide resolutions to mitigate burnout. So we found in total 47 studies based on almost 25,000 physicians, as far as I remember. And then we found that burnout is associated with 2 times higher levels of patient safety incidents, 2 times higher levels of low professionalism, and then 3 times reduced patient satisfaction. Among the components of burnout, depersonalization, which is mainly cynicism and distancing, having a distance with the patient's needs and the colleagues as well, had the highest impact on patient outcomes. So, which makes sense. Doctors and health professionals who feel less connected and with their teams and with patients are more likely to be involved in medical errors and show lower levels of professionalism. Our results were not affected according to healthcare system settings. So in any settings, the findings were the same across settings. And were unaffected also about the measures that they were used to measure burnout. So this has been the most comprehensive meta-analysis. I would say that recently it's not anymore. It has been another one, which is a larger meta-analysis. But anyway, up to that point, up to a year ago, it was the most comprehensive meta-analysis today, which provide evidence that burnout may risk patient care. So improving physician wellness is critical for sustaining the healthcare delivery and also ensuring a positive patient experience. So our findings basically mean that healthcare organizations have to invest on physician burnout at the same way as they invest for patient safety. So trying to say that we want high quality, safe care without having healthy and satisfied health professionals is unrealistic. So, and of course, burnout is, as we have already said, burnout is associated with turnover. Doctors who have high levels of burnout, they're also more likely to turn over, are more likely to retire early, are more likely to work part-time, and are more likely also to show evidence of absenteeism or presenteeism, so they can either be at work where they're ill. So some doctors basically doctors and health professionals are going to work in cases that they would actually advise their patients not to stay at home. This is called presenteeism. Or they also are more likely to be absent from their work because to avoid the toxic working environment. There has been a study which has been published about a year ago, which was trying to estimate the cost of burnout, taking into account its impact on turnover and also on low productivity. So the cost is quite high. Particularly high, and within this cost is actually these estimates are considered quite conservative because the impact on patient care is not taken into account. However, we can see that based on this analysis, in the US, about $4.6 billion are associated with the cost of burnout based on its link with turnover and low productivity. This means that at an organizational level, the annual economic cost associated with burnout related to turnover and reduced clinical hours is approximately $7,600 per employed doctor. So this is the impact that the healthcare system have by having ill doctors and health professionals. And then the main challenge comes to what can we do to prevent and mitigate burnout in health professionals. There have been two main streams, let's say, of interventions over the years. The first category of interventions are focusing on improving the health of health professionals as individuals. This means that they could recommend interventions such as meditation techniques, improving problem-solving skills, stress management techniques, communication skills training, and self-care workshops as well. And these types of intervention have been very popular over the year, and actually they can be helpful because they help, they support health professionals in their well-being as they would do with any, in my personal view, as they would do with any person who's working hard in their profession. The second type of intervention are less common, and they're mainly organizational interventions. These interventions focus on improving the system in which health professionals are working in. So they provide motives, and they provide also some protected time to physicians or health professionals. They provide shorter shifts and attending rotations. Try to improve professional relationships and teamwork within health professional teams. However, most of these have been mostly local-based interventions, so they're less developed, organizational in nature, but less developed than individual-based interventions. The main argument in the literature is that if we accept that burnout is an organizational problem, our main hypothesis would be that organizational interventions might actually be best placed to mitigate burnout compared to individual-based interventions. We tested this hypothesis, and we examined which interventions are actually most effective in reducing burnout in health professionals. So our main research question was, are existing interventions effective in reducing burnout? And what types of interventions are the most effective in reducing the burnout? Again, we identified 19 intervention studies which have been tested as part of clinical trials or at least controlled intervention designs. And we found that overall, the interventions that exist in the literature are actually effective, have a small significant effect in reducing, small to medium significant effect in reducing burnout. However, we found a major difference based on the type of intervention. So organizational interventions were twice more likely to achieve, to improve burnout compared to individual interventions. So if you see in the literature, for example, the effect of organizational interventions were standardized mean difference of 0.45, while the effect of individual interventions were minus 0.18. So at least twice as effective as the individual interventions. So there is clear, based on the findings that we have in the literature, there is clear evidence that burnout is associated with the performance of healthcare systems, and is actually shaped within the healthcare systems. And in order to mitigate burnout, we need organizational interventions. Of course, individual interventions are also important, and there is a scope for combining individual interventions with organizational interventions. However, simply providing individual interventions to health professionals might not be the most effective approach, mainly because individual interventions have been mostly misinterpreted and put the blame on health professionals. So health professionals feel like they are said that they are weak and they need to improve they need to account for their shortages and their shortcomings, and they see burnout almost like their fault. And for that reason, they need to strengthen themselves and they need to create resilience. However, what the evidence shows is that it's not about the individual, it's about the healthcare organization, about the toxic environment. And unless the toxic environment is actually addressed, burnout is not going to be mitigated, at least at scale. So, and what types of interventions, in terms of organizational interventions, what types of interventions actually improve, reduce burnout and improve well-being? It looks like there are those interventions that are changing the balance and prioritization within of the tasks in health professionals. Improve the practice arrangements within the hospitals, and improve also the professional communications, professional communication and the relationship within the healthcare organizations. So overall, based on what we have found so far, burnout is a problem of the whole healthcare organization rather than individuals. And the results show that putting hardworking healthcare professionals within a toxic environment is the reason why they feel burned out, because actually they're unable to succeed. So in terms of, as an overall figure, in terms of trying to mitigate burnout and improve the well-being of health professionals, there are different aspects that they need to be recreated within the healthcare system. And if these are optimal and well maintained, it can lead to engagement, while if they are not optimal, they can lead to burnout. So in total, in terms of the association between burnout and patient safety, are very highly linked. I would say are the same, are different are the different components of the same structure. So both are showing safety culture. One aspect of safety culture is patient safety. Another aspect of safety culture is burnout and the well-being of health professionals. So in order to improve patient safety and professional well-being, health professional well-being, we need to engage the similar types of organizations and policymakers as we do for patient safety. For example, we need medical associations, we need government policies, and even patient organizations as well, because it is important. It has to do with their own safety. So it's important to improve burnout and patient safety, to consider them as highly linked aspects. Thank you very much. Yes.
Okay. Thank you. Yeah. Okay. I will proceed in two steps, maybe, if you allow me. First, of course, thanking you for the speech, and I would just maybe ask the room if there are questions for Maria first. Just limit to questions. We'll have time for quotes and comments a little bit afterward. But let's start with questions so that we can run out of the questions. I think Kris has a question.
Thank you so much for that presentation. Fantastic. Nice to see that work happening. One of the questions that we're interested in looking at the moment is, and I don't know whether you picked up on it, is the direct impact of policy in causing toxicity, for example, in terms of imposition of efficiencies within health systems, and to drive cost effectiveness, etc. To what extent does that become a causal factor in toxic working environments and then contributing to stress and to burnout and to reduced levels of practice and reduced levels of efficiency?
When we were discussing about models for healthcare planning, I would say the well-being of health professionals should be factored in as one factor of within the models in terms of efficiency in healthcare systems. So I think at the moment they don't really take into account the well-being of health professionals as one of the factors that might impact on the efficiency of healthcare organizations. So what I would say is that policy has a direct impact of course, and unless they take into account the well-being of health professionals and try to introduce policies and allocate resources in improving the well-being of doctors, finally the impact on they're going to have less effective, less efficient healthcare systems anyway. So one part of the resources and prioritization of policy should be on health professionals themselves. I hope.
Did you, when you were doing, sorry, I'm
yes.
this is really interesting to us at the moment. When you were doing your research,
yes.
did you find a considerable evidence, and maybe we can pick it outside, but did you find a considerable evidence base that we could perhaps draw upon to start influencing the debate around this? Because one of the things that we've tried to do is to do sort of a desk-based research review to find about the direct, indirect, and unintended consequences of efficiency seeking. But the actual direct evidence of that in terms of literature, a lot of it's from the States, but it's all around doctor pay, etc., not around efficiency per se. So,
I mean, it depends on how you define efficiency. I mean, what is your main outcome basically? If it is about costs, if it is about numbers of, if you can let me know about your outcome, I can. Yes.
Okay, I think Ronald had a question, and his neighbor has as well. Well, I saw two hands here, but maybe two hands.
Okay. Well, thank you very much also for the presentation. One remarkable outcome of your meta-analysis is that there were effects on between the relation between dissatisfaction, burnout, and patient safety, but that was regardless, as I can quote you, regardless of the healthcare setting. So how can that be? I mean, before that you show us the model in which organizational culture and context factors are important.
So it didn't depend on the specialty. It does depend on the culture, but it didn't really depend on the whether the research has been conducted in family physicians or it has been conducted in internal medicine doctors, or it has been conducted among surgeons. So this is what we meant by setting. We meant specialty basically.
Still, that's interesting. Why you don't find differences between specialties?
Yes, that's.
Specialties are different in the type of work and the type of culture.
I mean, the main difference in terms of specialties is the rates of burnout. So you can find there are some specific specialties that have higher levels of burnout, but in terms of links with patient outcomes, it's the same. So.
We have many questions. So Malta first, ladies.
Is it okay?
yes, yes.
Thank you. Well, thank you very much. Very, very interesting, very, useful evidence using meta-analysis as well. I'm interested about time as a construct, since burnout is a dynamic downward spiral rather than a static end state. Of course, we consider the three dimensions as often very much distinct. When you were considering the interventions, at what stage were the interventions considered? Usually it's emotional exhaustion, right? In many papers that seems to manifest itself first. At what stage was the intervention done? Because I think it makes such a big difference since this unfolds over time. Thank you.
That's a good question. I would say, well, in terms of stage. Well, I mean, obviously the studies they had. I would say most of them, they were not that designed around the stage of burnout. They just took health professionals who showed some signs of burnout. So we don't, they might have health professionals who have really high levels of burnout and professionals at with low levels of burnout. They didn't do any separate analysis in terms of whether the interventions were more likely to be be preventative interventions. So they reduce burnout at very early on, or they could also work as reductive intervention. So basically they reduce burnout even when it is really high. So we don't know that yet, to be honest. However, based on the literature and the evidence, the earliest the intervention, the better. Because what's happening if burnout sustains for quite long, then it is more likely to lead to depression, and it is less likely to be mitigated as well. So I would say early prevention is really important, but we cannot really argue that based on the findings that based on the literature. We need more studies. Yes, we need more studies, and we might need studies at focusing on doctors who have only a few symptoms of burnout to see whether we can actually prevent burnout at this stage. And it can be also a more cost-effective approach because you allocate only limited resources and you keep health professionals healthy rather than waiting until they become really ill and trying to reduce burnout at that stage.
Please. Thank you, Maria, for this presentation. It was very interesting and very useful. I would like to ask you about an aspect of the problem that I kind of missed. We see that a lot in my country, in Greece, that especially due to burnout of healthcare professionals and mainly nurses, we see mobility. So we see that many nurses, but also doctors, in a way escape from their settings and do other jobs because of burnout. I would like to ask you if you have addressed this aspect in your research. Thank you.
That's a very important point, and we're actually testing this right now in the UK. We're doing an observational study in primary care practices, and we're looking at whether burnout is associated with higher mobility across the country. It looks, based on the literature, I would say that there is a strong relationship between mobility and burnout, because basically because health professionals feel trapped in their practices, and they try to find an escape, and they go to different practices, and at the end, if they're not satisfied in the next practice, then up to the point that they feel that they're completely disappointed with their work environment, and they might decide to quit at the end. But I think this is the first step of trying to move around in a way to find an escape from the working environment.
I suggest we take two more questions, and then we organize a more participation on the questions for the session. I'll start there.
Thanks, because I think that this is still an issue covered by stigma, in the sense that there is still the idea that burnout has something to deal with your personal dimension, and that actually it's something that is just showing that you are not fitting for the job, or it's a kind of inadequacy. And institutionalize this problem, especially from social partner side, is very difficult. My question would be, because I've understood this is a rather US research basis, I'm wondering if you have some data concerning the situation of Europe, in particular on the measures, in the sense that how many countries are implementing certain measures to reduce burnout in hospitals, because we always try to work through indirect measures, for instance, working on violence, on staffing levels and so on, but never managing to have a direct element to this. Do you think that the awareness is moving, it's enlarging, also expanding in Europe?
Again, a very good point. Yes, most research is based in the US. We have had some studies across Europe a few years ago showing that burnout is high in European countries as well. So at least 30 to 40%. So there is the findings are not very different than US, actually similar. In the UK as well, where they had measured recently burnout and they found the same findings. In terms of actual awareness. In terms of awareness, I think we make progress in the past 5 years, that many medical associations, many societies as well are increasingly asking for presentations, or they present findings around burnout. So there are some positive movements. But in terms of actually interventions and initiatives to target burnout in Europe, I think we're yet limited. I'm not sure there is anything at scale. There might be some local initiatives, but nothing at scale, at country level, as far as I'm aware.
And the last question for this question session. You asked for it, Andrew.
Thank you, Maria. I want to clarify what is meant by protected time, right? In what terms, protected time? And the other thing is, one of the drivers you mentioned is support, right? Was the support in terms of the leadership style of within the organization investigated, and whether there has been any relationship with burnout in your meta-analysis?
Well, in terms of protected time, it is usually health professionals are encouraged to self-care or engage in interventions, or even update their skills. The problem is then that they're expecting to do that as part of their spare time. They're not really covered for that time as part of their job. So some interventions, what they try to do is to increase, to give the health professionals the ability to train more, the ability to self-care, but within the time that they accounted as part of their work, not to do it as part of their extra time. And this meant actually, in addition to the actual time, I think this was mostly emotional, because health professionals felt that they are valued by their health organization, that this problem is recognized as problem of everyone rather than just stigmatizing individuals. In terms of leadership, yes, there is literature showing that the leadership style, that the good leadership is actually associated with burnout. It's one of the key factors. When all the organizational interventions, one aspect that they focus is about leadership. How good is the leadership? How well is the team is functioning? And support is again. A subjective term, is mostly the feelings of health professionals, when they feel, whether they feel supported and engaged within their teams or not. For example, we showed that there is a relationship between burnout and medical errors. However, this relationship doesn't mean that burnout always leads to medical errors. It might mean that medical errors lead to burnout. So when a doctor and a health professional and nurses that are engaged in a medical error, is about the support that they receive afterwards. Are they really supported or just blamed by their team and management? Yeah.
Thank you. I really hope the recording went pretty well, because all what you said and what the room asked was really interesting. I hope we will succeed in putting that also written. So the next part, we still have 25 minutes left, and I think I will ask you a little bit unusual exercise, but I think the discussion on this topic is really important. You all know in all countries almost that there have been quite a lot of strikes in the healthcare sector for different reasons. But if you take the full press review, lots of reasons are related to working hours or incapacity to be replaced and take holidays. Of course, also other working conditions like wages, violence, and things like that. So it's multifactorial. What I don't read in any press review is that the health professionals are demotivated, that they don't want to exercise their profession anymore. On the contrary, they suffer from not being in the capacity to deliver what they want. So the topic is really important. Of course, we are here in a setting of health workforce planning. So what can we at the planning level, I mean at the policy making level induced by planning, do about it? And so the question that we had put are of course related to the impact of that. How can we just not only discuss it, but transform it into planning, or even threshold to say, well, we can understand that facilities may have temporarily too few resources leading to a big burden, but there is a threshold when a snowball effect will occur and the situation will worsen. So I would suggest a little bit unusual exercise, but it's a workshop. It means that we aim at having you connected and talk with each other, even though you don't maybe know the neighbor. So I will just leave you 5 to 10 minutes, something, to just talk to your neighbors per table. Maybe you know your neighbors, maybe you're just scattered because you came out late or you just took the first seat, whatever. So maybe it's an opportunity to know someone you haven't spoken to yet. And on these two types of question, planning and thresholds, give me then a quote. We got something like 15 tables, so if I leave you something like 8 minutes to discuss with your neighbors, first of all you happen to know the neighbor, and then your table can give 1 minute quote on each of the items. So let us try that if you allow me. Of course, these two first tables for the setting, you just come together. But I think the other tables, it will be a good exercise. So please make a lot of noise by talking to your neighbor. Okay, dear colleagues. Dear colleagues, please, I have to cut your debate now. We gotta restart. Paul, we gonna restart? Okay, so if you allow me, it looks like a successful thing to have you talk to each other. Fortunately, there is a coffee afterwards, so you can just continue these vivid discussions. Now the exercise is that at each table, this was a speed dating, so you had something like 10 minutes, so it's speed dating. You know everything about your partners now. So in this setting now, I will ask the first table, I warn them, to one of the person will just quote or give their feeling about not all the questions, that's not important, but something related to those questions, what they discuss, what they think, what they want to share with the room from their discussion, and then I will pass the microphone on to each table with one person. Please stick to a minute per table, otherwise we'll skip the coffee and nobody wants that. Okay? So, I'll hand you the floor, and Walter and I will try to keep a note of the keywords of your intervention. And maybe you could, because to address the room, you better stand up.
Oh, sure, of course. So we tackled the first question, and we believe it's very important to define what work environment is. Within healthcare settings, very complex, and issues related to work environment would be leadership, teamwork, whether and leadership in particular, whether it is to avoid having people with toxic leadership, teamwork, whether it's well-functioning, also the complexity of the tasks, whether there's enough time for healthcare professionals to finish their tasks, rather than be frustrated not having done enough. And of course, the resources that the organization provides in actually doing their tasks well. But the impact, although it is already stated, job dissatisfaction, intention to leave, and also the profession, there are sort of those could lead, like job dissatisfaction, could lead to conflict at work, could lead to issues of harassment and these. Even when it comes to absenteeism, sometimes absenteeism, although a sick leave certificate is asked from employees, we have also the issue of presenteeism that's raising its head. People do go to work, but they're not actually working. Intention to leave as well. Sometimes it's possible to leave the workplace, at other times it is not. So the impact in terms of the outcomes there needs to be explored further. There are more outcomes than those.
Thank you. I see you're really interested in the thing. Yeah. All your hearts on the table. Who's going to speak for you? Vasily looks like the designated person.
Okay. So we had a quite vivid discussion, sharing country experiences and lessons learned between Greece and Slovenia. We agreed on all the aspects. We mainly focused on burnout in primary care settings, because both countries have lately implemented a new system regarding primary care. And even though both countries have done many steps towards a new system, we see that burnout is persisting in these settings, although normally it should be a more relaxed, let's say, a laid-back setting compared to a frontline hospital. In primary care, we see that many of the health professionals, for different reasons, develop a kind of cynicism and absenteeism in their job, either because they have too many registered patients, like for example it is in Greece because of the ratio being very high, or because the infrastructure is not satisfactory. They lack basic tools and computers to do their job as they should be doing it. So we emphasized on that, and of course the impact is very, very high and leads to patient safety and productivity issues. Thank you.
Thank you. The next table, you're gonna speak.
Yeah, thank you. So I must confess that we have not discussed that systematically, because we were all thinking that is really an important issue. So we must do more work. We were finding out, we are from Estonia, Belgium, and Germany, and we found out that that is done differently. So we found, I think, in all our 3 countries, that there has not been done enough research. And also the idea was to do more research on that and to bring the different stakeholders together. So in some countries, for instance, like the Nordic countries or Germany, there's done research by the insurance funds also, and but not everywhere. That would be an idea to also see who could we bring in as stakeholders to do more in that area. But sorry, it was a little bit unsystematic. But the main message is really important to bring that into health workforce planning. Thank you.
Thank you. It's also a call of interest, I guess. On the next table, who's going to speak? Everybody's looking at each other. Okay.
Okay. Good morning. Our introduction was to introduce ourselves, because I'm the first day today, so we had a really nice introduction, and we discussed 2 parts. First of all, it was a discussion about what is the impact of creating basic patient to caregiver ratios, and what is the impact of a safe environment on preventing burnout. And on that discussion, we also explained that the burnout is an end stage, and at that, when you reach when an employee reaches a stage of burnout, that is a really the worst case you can have, because it's a real issue to reintegrate them afterwards and so on. So the second part was, well, how can we see it on an earlier stage? And then we discussed an example that in our hospital is running, and some of colleagues know that, to have a really easy to reach colleague coach. And we also have that example for medicine, but also for nurses. And I'm really convinced that that way of working, to have easy to reach colleagues that are willing to listen to you and to help you in your orientation, in your problem, that could help preventing the end stage of burnout. That were the 2 discussions. It's okay?
Excellent, thank you. This table, who's gonna bring the word? You're pointing at each other, so who's gonna do it?
No, but we had a different discussion.
Oh, so there are 2 tables on 1 table.
Speaking Italian, that's...
I'll say, you got 30 seconds each.
Yeah. Okay, then in these 2 seconds I will say that the study and studies about burnout, you can find it in a year ago, general publication from Wilmar Schofferly, from the Netherlands, from Nijmegen. He was making real the past, what happened now, and what will be the future. I think that's important to read that. And if everybody knows what in that book was, then you know that we start about burnout more than 30 years ago. In his first lecture, he was in Spain with our organization to explain the burnout in the continuous system, from prisons, from nurses who work 24 hours, and the influence on that. Later on, he was making the study special on nursing, and that's important for us, I think, and that we talked about, we too. And that the colleagues, I don't know what
if you provide the reference, we will put the reference with the
we spoke about it too, and we agree that it's very important to make prevention steps of burnout, and it's also quite difficult to implement some steps to planning of workforce with some elements of burnout. But it's, for example, in Czechia, we have quite known analysis or surveys about this topic, and I think that we have to make some focus on this topic.
Thank you. We will send the reference.
Wilmar B. Schofeli. Professional burnout, recent developments in theory and research.
Who's going to be the spokesperson from your table?
Well, I can say a few words that we discussed a Danish case. The half of Denmark just changed the digital systems. They deleted about 20 systems and started a new system from scratch, an Epic-based system. And of course, it will be great one day, perhaps in 10 years or so. But meanwhile, it's a slow system and it makes a lot of mistakes. And the doctors are afraid of patient safety. And it was some years ago it started, and everybody was hesitating to say anything about what they really feel about this. But now people are really angry, and we see a lot of burnout because there's this workload, as it always is. And then at the same time, you're working slower, you're afraid of mistakes, and things are just not working properly. That's quite severe in the east part of Denmark at the moment. So maybe it's a case you will hear more about.
Hopefully, yeah, maybe not. I hope so. On your table, Usman.
Thanks, Michelle. Morning, everyone. I'm sorry I wasn't able to join yesterday, but very happy to be here this morning. We immediately went sort of disruptive and didn't sort of address those questions, but we're talking, linking on with issues that we raised yesterday in terms of patient and public engagement, and the idea of the consequence, I think the twofold consequence of not involving patients and its impact in terms of increasing the workforce stress, but also the idea of patient-centeredness, and that if you don't have a patient-centered model, that also exacerbates any issues in terms of workforce stress on a sort of more existential level. And then we were talking about notions about whether we should be just talking about patient or also talking about service user or having a wider sense of them, but we sort of brought that part into the discussion.
Thank you. So we already had 7 tables and different insights, which is really very important. Have you... Well, you're the spokesperson.
Yes, thank you. I was just thinking about Wilmar Schofeli's results, as Bert was mentioning, the publication. And many of you know me, I'm a very optimistic person, so I would like to highlight the other side of the scale. Not only the burnout should be in the focus, but the work engagement. So if we are aware of different strategies, how to boost up the work engagement of professionals, being as a manager, being as a policymaker, being as a practicing professional, it could be very, very beneficial. So just we should not forget this part of the scale. Thank you.
Thank you. Could you pass it? Yep. Don't fight for the recorder.
Okay.
Nobody there.
Nobody. Well, nobody wants to, but somebody has to. So we basically kind of touched on all of the 3 questions and also talked a little bit about that it's very difficult to measure how to factor burnout into the health workforce planning. We talked a lot about that different factors actually impact how satisfied you are with your job. And then what we kind of ended with was an example from Lithuania, where after a case where a supervisor had a lot of impact on terrible health outcome for a healthcare worker, a system was implemented via which you can anonymously report things that are going wrong in your institution, so that you kind of lower the barriers of actually speaking up and pointing out certain things that should maybe change to increase job satisfaction and to lower burnout related outcomes.
Thank you. On this table, who's going to be speaking?
Okay. The shy one. Yeah, why not? Good morning, everybody, and welcome again. I would love to be what our colleagues at the back called distractors, or no, disruptors. Yeah, yeah, we were disrupted, all right, but I don't think it was in this conceptual sense as you were talking about. So, we want to thank Maria for the data that she provided, because it was very, very stark, and because I'm Irish. So therefore everybody else is Irish. We think health budgets are always going to be compromised no matter how wealthy or poor the country is. When we hear data like that, the two questions I ask is, so what and now what? Yeah. So what? So what? We've got this data, but what are we going to do with it? So from our perspective, what we thought was, the first thing we need to do, and maybe SEPEN needs to be involved in this, is look at collecting the data, particularly from the impact, the economic impact, because at the end of the day, if you can show there's a cost associated with this, we may also show there's a cost or there's a benefit in investing in some of the preventative measures that could lead to a reduced burnout. And we suggest a pan-European study to capture that economic data, focusing on all the positive issues as well, but actually trying to capture a pan-European data set that has the economic impact of burnout. We also felt that things like regulatory impacts hugely on burnout because of its compression of people's time, and I don't know if that was captured. So what we said, now what, is that this type of data at a national and pan-national level with a huge economic impact should be influencing health policy, which should then drill down to human resources planning, which then should drill down to human resources policies, which then should, in our opinion, impact on the working environment, but provide a clear economic return on investment and value for money. Thank you.
Thank you very much. You're the spokesperson.
Yeah, the shy one. So, yeah, listen, it's hard to confront that side of the audience and that side of the audience at the same time. So I'm going to do the alternative. I'm going to move over here. It's a lot of everything that's been said today we absolutely agree with. Just a couple of factors. The UN High Commission on Employment and Economic Growth said that for every pound, dollar, euro you spend on health, you get a nine-fold return. For every year of added life in population, you get a 4% growth in GDP. When you buy a big white box to put in a hospital, you invest in maintaining that box. It's important. Our workforces are the biggest part of our cost expenditure within health systems, and we must invest in them, not see them as a cost to be controlled. And that means that we have to invest in their workplace health, their workplace contentment, and ensure we get the most productive environment for them to work in. To engage in policies that impact on an ability of an individual worker to deliver the best that they can do is economic suicide, and no corporate entity I know would do that. So why health systems seem to see it as a mode of operation is lost to us.
Okay, the smallest group here, just 2 people. We basically focused very quickly on the personal level of burnout and how we can help people to detect burnout early, quickly, maybe self-assess using, for example, apps or other tools, and then moved on that also it should be an important factor for, like in Belgium, the test, if you can study medicine, that we would check not only for hard skills and soft skills, but also the ability to self-assess one's own stress level to be able later to find out if one is on the verge of a burnout, not only when it's too late.
Thank you. And the ultimate group. Who's going to speak?
Just 2 things, and then some general
reflection or information. So what we discussed in our group was, we are talking about risks for burnout, but so well, I think still one element what is quite interesting to focus on is on clinical manifestations, what we see in practice when we talk about absenteeism, about what is the real, it's not 50% of our people are burnout. It's risk of burnout, but what is the clinical manifestation of burnout? The second thing what we talked about is that that organization, individual dimension, but it's also about thresholds. So what are the thresholds? When you're passing and you are decompensating as an organization or as an individual. And I think it's not black and white, so it's in the middle, and it's a little bit more difficult. So that's what we were talking about. Just to give your information, and just for closing this session, I think, if I may, Michelle, is Maria was saying, at this moment in time, there are no real interventions and so on, and I think it's right until now, but because there was an interesting call from the European Union last year, in which there were some projects, we also were awarded with a project. And our project that we will do in 5 countries, 60 hospitals, is really work do an intervention study in remediate the toxic environment of doctors and nurses. So it's really going into leadership, into organization, into creating supporting environment, and we will do the test. So it's quasi-experimental design with all the what you can imagine. We are focusing on burnout, and we also focusing on engagement. And I think it will be the first larger study in this area, but because I think we have to bring the knowledge that we have into implementation intervention. So that's what we are starting from the 1st of January. We have our meeting next week, first meeting, and then it's a planning. But we keep you informed. So we will share, we will share.
So thank you for this vivid discussion. It was worth it, and I think we took 12 minutes over, but we will not get 9 times the investment as Kris subject. You don't have 9 times the coffee time. We'll still try to a little bit hold the timing for the coffee. So if you allow me, in 25 minutes maximum, we'll get back here for the second plenary discussion on these subjects. I will thank you, the speakers, again, and to all of you who have been voluntary to bring the results of your 10-minute speed dating. Thank you. And I think you still have the same time, an hour. We had foreseen some time during the lunch to be able to shrink it a little bit, so it's okay. Please make it.
Okay, thank you, Michelle. Good morning, everybody, and welcome to session 2 of day 2 of our workshop. John Delamere is my name. I'm from Ireland, representing the Health Service Executive, which is the major statutory provider of health services in Ireland. But I am also here representing HOSPEAM, and maybe just very brief explanation of who HOSPEAM are. They are a representative body for employers in public and private sector across Europe at a regional and a national level. And at the moment we have a footprint in 13 countries and hoping to expand that in the near future. Big areas in which HOSPEAM are involved at the moment are in the whole area of continuing professional development, lifelong learning, the labour market, workforce planning, and obviously the area of industrial relations. We are also working together with the European Public Service Union, EPSO, under social dialogue. We're a recognised partner at European Commission level. And that involves where, on behalf of employers, we're consulted on areas of change in that sector. And I suppose one that's worthy of mention would be the directive in respect of sharps, needle stick injuries, which was something that came up and was discussed quite an amount, eventually became an EU directive and has been transposed into national legislation across the EU countries in more recent times. Moving along then to the theme of this session, it's from second victims to joy at work. And I suppose we all know and we all recognise that no matter how well we run our health services, there are going to be adverse incidents. And obviously the first people, the priority, and rightly so, when an adverse incident arises, is the immediate victim and their relatives. However, it affects other people. It affects the professionals that are at work and who have been partly involved in that. And it leads to a situation where maybe perhaps the person, guilt and anger, a feeling of, could I have done better? And adding on to that then, in the eyes of their colleagues, in the eyes of their community in particular instances, can it have an adverse effect on the person's longer-term working career, have an adverse effect on the person at home? So there's a varying degree, and I think up until now it's probably been a neglected area. But I do think, and I think there is indications that that is now changing. So I think that's the theme of this session. I mean, it is certainly looking at the adverse effects of same, but I think moving to, how it can be addressed, how it is being moved forward, so that there are two aspects. There's a positive and a negative. So I want to introduce our main speaker, Kris Vanhaecht from Leuven University here. So Kris will speak to us for about 20 to 25 minutes. And after that, then we'll have questions and answers, and we'll give consideration to maybe doing something very like what Michelle done at the earlier session and get people activated and take us up to lunchtime. So without further ado, I'm going to hand over to Kris at this stage. Thank you very much.
Thank you. A very good morning to all of you, and thank you for the invitation. And thank you to my colleagues at Leuven University to organize this. I'm teaching quality and patient safety here at Leuven University to different groups. I'm linked to Leuven University and to the Erasmus Center for Care Policy in Rotterdam also. What I would like to talk to you about is not about the data about adverse events, because Maria, of course, did it, and I will quote some of her work later on. But I used also a subtitle, not only from second victim to joy in work, but also what we call from adverse event to mango moment. And adverse event you know about, mango moment, I can imagine that you never heard about it, but I'm sure that when you're this weekend at the supermarket and you will find a mango, you will think about this session. And I will explain later on why we use the mango moment concept at this moment. So I don't have to go into these details because these are based on Maria's work and on other work, the 10% of patients that are involved in adverse events, and the data that are there from not only Maria's work, but also the main manuscripts that were written in 2018 by the WHO, by the OECD, and by World Bank. And it means that we have to care for our patients. But I think it will be a struggle, and we have to think about it, how to take care of patients, of course. But back in the year 2000, that's 20 years ago. Can you imagine? I was teaching this week at the Masters in Biomedical Science, and I was asking these people, hey, do you remember the 1999 report To Err is Human? They were looking at me, and I told them, how old were you? And one said, -1. And I was thinking, I'm getting old. Yeah. So it's 20 years ago, the 1999 report, more than 20 years ago. when it was 1 year after the To Err is Human report that my good friend Albert Wu, who works at Johns Hopkins, he wrote a paper in the BMJ, Medical Error, the Second Victim, the doctor who makes the mistake needs help too. And he was the first one who used the word second victim. Of course, there were papers from Lucian Lee before in the 90s, but it was Albert who introduced the word second victim. And he said, it's not about medical doctors, but of course it was in the BMJ, in the British Medical Journal, so he used the medical doctor, but he says it's about nurses, pharmacists and other members of the healthcare team that can be involved, and they will not be okay afterwards. And in the first years after he introduced it, not a lot happened. It was only in 2008 that there was a first definition about second victim. We started our work on second victimness about 2010, 2012. In Belgium, in the Netherlands, but also in other countries, for example, in Italy, but also collaborating with people and with colleagues worldwide. As it was explained clearly in the introduction, it's about, we call it the second victim after adverse events, and there is discussion about the term second victim, mainly because of first victims. The first victim is the patient and the social network of the patient. It's not the patient anymore. It's the patient, the family, and the social network. And they stay the most important victim of an adverse event, of course. There is a negative reaction on the term second victim, as people say, they're not the victim, the second victims. They did it. When I launched my work on second victimness about 10 years ago, we received telephone calls, anonymous. People were telling us, "What, you are taking care of murderers?" And so the last 2 to 3 years, it's getting okay, because also patient associations and patient representatives and patient advocates understand that if we take better care of the second victim, also the care for the first victim will improve. It's about open disclosure and all these things. But it's not only about the first victim, the second victim. There is also something that is very important for you, not only the second victim, but also what we call the third victim. The third victim is the organization where it happened. And it's about reputation. Not only reputation, but we know, not of hard data, we don't have hard data about it, but we know of cases, certainly when the adverse event comes in the news, and in every of your countries you know the newspapers that you don't want to be in with these type of things. Yeah, the gossip magazines. But if you're there, we know that the number of no-shows increase. Patients don't come to that hospital in the weeks afterward for that specific thing. So it has an important thing. So what is the second victimness all about? It's about the healthcare professional, the perceived responsibility. It's not that he or she did it. It's not that it's about a medical error. It's not about illegal. It's not about claims. But it's the perceived responsibility by oneself or others for an unanticipated patient safety incident. And that's important. So the first papers that were written about the concept of second victims were about what is it all about, and case studies, and mainly US related discussion papers, not research papers, but discussion papers, where they talked about this is the way that we take care. I do it in my organization like this. What was unclear, what is a second victim? We know what it is. It's a healthcare professional involved, and he or she has some problems afterwards. What we published recently is a study that was based on data from the Netherlands, where we included 30 hospitals, and where we did survey research to find out what the symptoms were that second victims have, because these are the most important thing for the human resource management. We can say, well, it's a second victim or not, but the thing is, what are the symptoms that they have? And if we know these symptoms, we maybe can take care of, or we can understand what is happening. So what we asked them, and all these people told us, well, we were involved in an incident, and the incidents with the different levels of harm. But we also found that with only minor harm to the first patient, the impact on the second victim could be incredibly high. So there is a link, certainly in nurses, there is a link and a correlation between the level of harm for the first victim and the symptoms of the second victim. Yeah? But if we look at the overall group, we now have an idea about what are the symptoms we have to look at. What does it mean, second victimness? And what I will show you on the next slide is a list of symptoms that came out of literature and of case studies and of qualitative research that we performed. And then we asked to these healthcare professionals, do you recognize that symptom? And do you remember how long, what was the duration of that symptom? Because it's not about that you have that symptom for one day and then it's finished. No, maybe it was longer for certain symptoms. And these were our data. It's published in the BMJ Open, so it's open access. You can download the paper. It's based on a study of about 7,000 healthcare professionals, 30 Dutch hospitals, all type of general and academic hospitals. And what you see here are the symptoms, and I will tell them to you because maybe it's a little bit too small to read. But also the colors are about the duration of the symptoms. So of course, the darker red, it's the longer. The darkest red is more than 1 year. The green is never, never. There were about 5% of the people involved that said none of the symptoms. There is research that 5% of people working in healthcare are crazy. I'm not sure if that's linked to, but that they don't have emotions. And so it can be that some people say, I'm involved now in a case with a junior medical doctor who tells me, no, it's a learning curve. I know that it would happen. Can you imagine? That's not okay. So he has to go in therapy, I think. Yeah, but these are the normal symptoms. And so the symptom, and what you see here is the duration more than 1 month and more than 6 months. And if you look at the top symptoms, it's hypervigilance. Hypervigilance. Hypervigilance is not a positive attitude. It's not to think twice or to ask advice of somebody. It's to be really hyper. That's not good if you come to work and you're hypersensitive and hypervigilant. It's not positive. The second one is doubting knowledge and skills. And of course, there is the link with quality of care and the risk of new patient safety incidents. It's about stress, overall stress, shame. And then there is one of the most important symptoms that we found, and that is very high. It's the number 5, based on this research. And it means that 23, so say 1 in 5, 20% of the healthcare professionals, so these are not the patients, these are the healthcare professionals involved. 1 in 5, 20%, told us that they have more than 1 month of flashbacks. And in the DSM classification on mental health, more than 1 month of flashbacks is linked to post-traumatic stress disorder. So this is a thing really should be on the agenda of the human resource department in an organization. Because if we look at the relation of flashbacks also with the other, like fear and shame, can you imagine shame? Shame, nearly 8 to 10%, more than 6 months of shame, but that's not positive. But doubting knowledge and skills, also 27%, more than a month. Doubting knowledge and skills, we know, is the risk of being involved again in patient safety incidents. So these are the duration of the symptoms based, and they are ranked based on more than 1 month. Because more than 1 month is now in the DSM classification for mental health, the trigger for post-traumatic stress disorder, and we have to take care of the care provider. What we did so this was published in 2019, what we published in 2016 in medical care, was a study in 37 Belgian hospitals, part of a larger study on well-being and burnout in Belgian hospitals, about 6,000 medical doctors and nurses. And there we found an association. If we looked at the group of healthcare professionals who were involved in a patient safety incident during the past 6 months and a group that was not involved, the group who was involved in the previous 6 months had a twofold burnout risk of the other group. A higher work-home interference, higher turnover intention, higher problematic medication use, and that was not paracetamol that they were taking. That was sleep medication, of course. The only thing that we didn't find a significant result on was excessive alcohol consumption. It was excessive alcohol consumption. And if we looked at alcohol consumption, normal alcohol consumption, 2 glasses a day, it was also high in the control group. We know that it's a problem. But we know that when people don't feel okay, that they come home and maybe they drink the 3rd glass or the gin tonic or, yeah? So we have to be serious about it. This is a risk because this is a risk, of course, for the next patients. So the work on second victimness is work about patient safety and quality of care to take care of our clients, of our service users. We did a study published in the BMJ Open in 2016 by our group, where we looked at the individual situation and organizational factors that are involved in second victimness. It means that we were looking about 913 clinicians who were all involved in an incident with harm to the patient. And then we looked at the factors. Female had a higher risk of being there. I'm still not sure, although we see it in a lot of research, but I think that ladies are more honest on these type of questionnaires than men when you ask, are you feeling okay? Yeah. Do you cry? No. And we know from case studies, because we did a lot of in-depth interviews, they cry, but they cry at 2 places. You know the ones? In their car, driving home. And in the evening when the partner and the kids are asleep. Yeah. We have to take it seriously. Yeah? So these are, we found individual factors, situational factors, but also organizational factors, the link with blame culture. And it means that feeling guilty, being frustrated and having fear is normal. It's a normal reaction after you were involved in an unanticipated patient safety incident. It's normal, but because of these symptoms, you are doubting your knowledge and skills, and doubting your knowledge and skills is the risk factor of being again involved in quality of care and patient safety. And so we have to think about burnout, of course. Maria, I agree with you, but I also agree with the lady in the back who was saying, hey, I'm the positive one. Yeah, I'm also a positive one, so I don't talk a lot about burnout, but I'm a fan of the IHI model of happy, healthy, productive people. That's the opposite. What are the things that we have to look at to have happy, healthy, productive people? It's my friend Jessica Perlow from IHI who developed it with Steven Swenson, the group of Schanafeld and that we all know. So it's on senior leader, on manager leader, and for example, they say we don't have to work with colleagues, and the colleagues have to be team members, but it has to be one level above. It's camaraderie. I really like the word. Yeah, camaraderie. It's one level higher. But the first thing that they say that has to be okay in every healthcare organization, if you want to have healthy, happy, productive people, is physiological and psychological safety. Taking care of the second victim. If that's not okay in your organization, people will not be productive in your organization. So we have to think about it. And that's the link with exceptional patient care. If we have happy, healthy, productive people, we can have exceptional patient care. Not good patient care with a score 8 out of 10, but a score of 11 out of 10. You know that the type of patient that tells you, hey, never broken your hip, it's really, you have to have, it's great in that hospital. Your ambassadors. So it means that it's based on 5 levels that have to be there. It's about evidence-based care and reliability, of course, but then we come on the human resource level. It's about respectful partnership with your patient and your service users. It's about hearts and minds, and it's only possible if in specific organizations there is a link with the organization level. That is with leadership. Not a leadership and your authenticity that you have in your heart or the way you are, but also the message that the leaders are providing. These 5 things have to be there. And that brought us about 2 years ago on one evening, we had a very crazy idea to do something about what we later called mango moments. And mango moments are small, unexpected acts or gestures which are of great value in the care experience of patients, residents, and families. And it's about normal care activities. The very small things that can make patients very happy and that they remember 10 years afterwards are very important to healthcare providers. And I will show you why we called it Mango Moments and to give you some idea what it was all about. It started during a program on television where a journalist was an observer at an intensive care unit, and she met a specific patient called Vivian.
Sommige mensen die op intensieve liggen, die vertellen ook dat ze dan heel akelige dromen hebben of akelige dingen zien. Was dat bij jou ook zo?
Ja. Ja, de hele dag van de familie bij me zitten. Iedere dag. Iemand anders van de familie bij me zitten. Maar mensen die alleen aan het dood waren.
Ja. Angstig, dat waren ja? Geen fijne beelden.
Nee. Ik heb nog geen fijne beelden gehad.
Nee?
Nee. Wat dromen, nee.
Geen mooie dromen.
Nee.
En die bange dromen, zijn die nu weg?
Die zijn geminderd. Zijn niet weg, maar ze zijn wel geminderd. Dat is een normale goed teken.
Ja.
Je staat vooral als dat een vraag voor een spuitje.
Een spuitje? Wat bedoel je?
Altijd gezien.
Is dit waar? Zag je het niet meer zitten?
Want hoe ga ik eruit komen? Ja, nooit meer dezelfde zijn.
En hoe kijk je er vandaag tegenaan?
Dat is het weer altijd zo.
Ja?
Kijk het eruit voor een beetje kunnen te eten. Ik krijg soep. Een patatjes voor de eerste keer.
Voor de eerste keer? Dus dat is toch ook een belangrijk moment?
Zeker. Ja.
Je hebt dus niks gegeten in al die tijd?
Deze zondevoeding
Ja.
Seks. Kreeg niks.
Ja. Ik kan me dat bijna niet voorstellen. Wij proeven heel de tijd, maar je hebt lang niks meer geproefd. Er zijn er al zo dingen waar je naar verlangt. Wat wil je graag nog eens proeven?
Een mango.
Ja.
Een mango.
En nog iets?
Eigenlijk alles, maar dat heeft mijn voorkeur.
Een mango.
Lekker.
Ja. Dus vandaag zet jij grote stappen toch?
Dat ik eigenlijk ook de vraag.
Ja.
Je wilt vooruit, je wilt
Tuurlijk.
naar huis.
Je wilt naar huis.
Ik wil naar huis. Jazeker.
Goedemorgen. Dag Vivian. Kijk. Surprise. En ook nog een mango drankje. Heb je nog altijd zin in mango? Ja, ik heb dus mango bij, omdat Vivian daar zo naar verlangde. Maar mag ik haar een stukje mango geven? Ja, dat kan je kwijt. Is een goeie. Wat zo zalig dat je zo terug van kleine dingen kunt genieten. Hè. Nee.
I will never ever forget that. She told, and I'm sure that she will never ever forget. She knows that we are here now. She wrote me a message this morning on Messenger. She's okay. She's in okay health, although that she lost both legs, fingers. She was 2 times resuscitated. But she remembers these little things, not the negative things, these very small acts and gestures of healthcare professionals or of people coming to them. And what we launched is a project first in 3 Belgian hospitals, but then my mango moment of the year was a Lancet Oncology about In Search of Mango Moments, where I ended my perspective. Maybe mango moments can make healthcare a little sweeter. It was around Christmas, and I think that the editor of Lancet was also a bit in Christmas. Otherwise, it wouldn't have happened, I think, my Lancet. All these publications with p-values, impact factor 2, mango moments, 33. Yeah, that's the important thing. But it opened up a lot of things. A lot of hospitals participated, and we went in search for mango moments. We went to search for positive things. We collected stories, positive stories. We received more than 1,000 positive stories, not about mangoes, about taking patients seriously. We performed more than 100 in-depth interviews, and based on that, we came up with a model about person-centered care where we say, of course, there are things that need to happen, and it's not only about a healthcare professional but also about the patient and the organization. But when this happened, and that was a surprising thing to me, of course, when these small gestures happen, we know that, of course, patients and family are happy. But out of the interviews came very clearly what the positive effect was on the healthcare professional, where they talked about joy in work, about anti-burnout, about engagement, about team atmosphere. And what it's all about is about positive resonance. It's the link that you have with your patient. And that is why we work in healthcare. A few weeks ago, one of our major top surgeons told me, hey, Kris, you know that I was smart enough to become F-16 pilot. I told him, yes, of course. He told me, but I've chosen for healthcare because of these things. And because of these small things, because after doing 1,000 hip fractures, I've seen it. But I stay loyal to the organization and to my work because of these small things that can happen. In management, we say it takes 2 to tango. Maybe in healthcare, at least 2 to mango. Yeah. So this is what it's all about, and we think that we have to take also that part. And that's why I think that it's not only about these 6 dimensions that we know from the IOM, the 6 dimensions of quality. We have to change it. At this moment, I'm writing a paper together with Peter Lackman from ISQA and Paul Betelden of Dartmouth and IHI, and we are writing a paper about maybe a new multidimensional model of quality where we say the person-centeredness has to be out there. It's not one of the dimensions, it's the umbrella, it's the overall dimension, and it's not about the person, it's about the kin, it's about the social network. And of course it's 2020, so let's bring eco-friendly in one of the dimensions of quality, but it will be about 4 core values. 4 core values in the middle of the model that we have to use as a service provider or healthcare professional to our patients, but also, and that's important for you, as manager to your healthcare workforce. And it's about dignity and respect. It's about holistic approach. It's about partnership. And it's about kindness with compassion. And about these 7 dimensions and 4 core values, we have to be transparent. Transparent, taking into account our patients. So that is why I think that quality of care is not only from second victim to joy in work, but also from adverse event to mango moment. Thank you.
Okay, thank you very much, Kris. That was a very thought-provoking and stimulating address. Now, at this stage, I might open it for some questions arising from Kris's address. Is there anybody who would like to kick us off? Everybody's gone very shy.
Thank you. I don't have a question, but I just want to thank you and the organizers for bringing these topics in. I think it is a very important sign also for the debate on health workforce and planning, that we bring these personal issues also more. And really thanks very much also for making us these more feeling. I worked for 10 years in intensive care, so I know what you're talking about. I'm from the UFA Health Workforce Group, and we also decided for this year what we called the human face, to make that a topic, and I really think we should all together strengthen these issues. Thank you. That was a comment.
Thank you. I really appreciate that. Thank you. Maria.
I just wanted to say that this was an amazing presentation. In a very good continuum from my presentation, because you were focusing mostly on positive things about the concept of second victim, which is even now in a lot of publicity as well, because I think only recently, like a few months ago, BMJ published another perspective on second victim, and we still, even though we have made progress, there's still many people making nasty comments over the concept of second victim, which I don't agree, of course. And what I wanted to say is about, in terms of the mango moment, it is one aspect of patient feedback and patient and interaction, and there is evidence showing in the literature that patient feedback, positive patient feedback, can be a very effective intervention in reducing burnout in health professionals. So we shouldn't underestimate that, and it is one of the way of giving feedback and making professionals more engaged, to give them some indication about how and what impact it has. we take it for granted. So when in hospitals, for example, they do statistics about efficiency, about medical errors, but very rarely they collect data about positive things. And these reports can be really helpful for health professionals. Are simple, they don't cost much, but yet they have a very positive impact.
Thank you for that comment and to add that information. I agree with you, of course, but we have to be careful. If I ask you the question, do you want an orthopedic surgeon? Which orthopedic surgeon do you want? The one who perfectly gives you a new knee and be average kind, or the very kind one who brings you lots of Belgian chocolates and mangoes, but does something wrong? So in the dimensions, so in these what I think, if I may, in these dimensions of quality, maybe there is a ranking in. But what we think and what I'm writing with Peter and with Paul at the moment is that only if you take your patient seriously and as a person, not as a patient, not as a client, but and not as a service user. So I don't know the word. That's why we use the word person and kin. Only if you look at the patient or that person that is in that bed as a respectful partner, then you will apply all your safety standards. Then you will do your time out before your surgery. Then you will give him the medication that he needs, and you will not forget. I know that there is a workforce problem, but I think that is the reason why we have to put it on as a kind of umbrella, but safety first. So if I would be a patient, I would rather have, prefer the nurse that comes in and tells me this is the medication, and that is the correct one. And the one say, "Hey, Kris, how are you? Here is your medication," and it's the one of the patient next door. So we have to be very careful with the person-centeredness. It's not the cherry on the cake. It's in the book that will be out in 2 weeks' time in English. It's available in Dutch at the moment, but it will be out. Victor Montori of the Mayo Clinics writes a part in it about the patient revolution, but also there is a part in it that it's not the cherry on the cake, it's the bottom. It what makes the cake. If you don't look from that perspective, and what we see is that, if I link it again to second victimness, Maria, what we see is that if I, in my work here at Leuven University Hospital, where I work 1 day a week as an advisor, and I work with medical doctors and nurses who were involved in incidents, it's important to also respect all the positive things that they are doing and not only focusing on the negative things. So for me, it's not like two sides of a coin, or it's one thing. We have to look at what we call at the moment, we have to do morbidity and mortality conferences, but we also have to do ANA conferences. And ANA conferences are awesome and amazing conferences. Awesome and amazing things that we did for patients. We can also learn from that, linked to the Safety 1 and Safety 2 work that is there at the moment.
All the way at the other end of the table, Kris. Absolutely love the presentation. Certainly made my journey out from Brussels worthwhile this morning. Two things. I don't know if they're comments or questions. I think in relation to those mango moments, I think there are a lot of workforce. You can see the sort of workforce mind map going out from that as an ideal. What do you need to do in terms of training? What do you need to do about interdisciplinary working? To be able to create space for those moments. And I think to be able to show the value of them, and you could see how that would feed out in terms of prems and proms if you had those mango moments. So that's one part of it. The second part then is to swap to the other side and to say, if we're talking about co-creation, there's going to be a lot that needs to be done on the health workforce side to be able to create space and to create legitimacy for those mango moments. But equally, when I saw that video and saw the patient, and you could see the journey, some elements of the journey that she had made in terms of self-care, in terms of where she'd come from, and just to say that we need to match up in terms of health literacy, health confidence, health advocacy, that so often patients are simply not prepared for the experience that they're going to go through. So they then go into that passive mode, which allows healthcare professionals to act in maybe not the most mango moment type of way. So it's just to say about that, needing both the sort of yin and the yang and the sort of taking two to tango.
Just to say one thing about it, I agree with so one of the reactions that we are receiving at the moment is we don't have time for that. And I agree partially on that. Because these are very small acts and gestures, and you don't need, it's in the definition, you don't need a lot of time. It's about the way that we respect patients, that we talk to patients, that we talk during taking care of them about the things that they're interested in and not about my world. I'm not talking to patients about photography, although I really like it, but maybe so these are the things that come out of the stories, that to take the patient values very seriously. And so I'm not sure that we need a lot of time. What we are doing right now is a new project in 40 healthcare organizations where, based on the model and on the book, we provide workshops to just make them think and have discussions between each other. But patients in the room, doctors in the room, but also the cleaning personnel in the room, because they are, for these type of things, one of the most important people in our health workforce. We forget a lot about them, but these are the ones that you have a normal talk with about life and just about life. So that's important. So these mango moments are not about organizing the VIP that comes to your hospital. It's not about a football team that comes to your hospital. It's you at that moment looking into the eyes of the patient and saying, I see you. That's about it.
There was somebody first? No.
Go ahead.
Thank you. I agree partly with you, but I think there is also the organization. It is not about time. I totally agree. It's not about money, but for me, it's very much about management and governance and the organization. And if you work in a unit or a hospital where this is communicated, so this is valued, then you feel as a health professional that you should do that. But if you work in a unit where, for instance, to keep with your examples, I can only confirm that from all my experience, is very often people who stay in intensive care is very often on food. Simple things. I would like a banana or so. That is what I have in mind, a banana, where you think, oh my God, is that your wish? So, and then it's not possible because you are told, don't you have other things to do? To care for this patient who might die, and you think of bananas. So if you get that message, then you won't do that as a health professional. So I think I appreciate what you're saying about the people, but I think don't forget about the organization, because if there is a different culture, and if you get your credit points, and if you're valued for these kind of things, then things will follow, and organizations should do much, much more things.
We're 1000% on the same wavelength about that. And it's also in the model, it's the upper right part. It's on organization level. Therefore, the subtitle of the book is Mango Moment, a small act of kindness and leadership. It's about leadership of also the middle management. It's about these people that make it happen. It's about culture. It's about organizational culture. And therefore, we know that in certain wards it will happen, and in others it won't, because of leadership. So in the book, a well-known in Belgium and the Netherlands psychiatrist wrote that the most negative thing that could happen is that JCI, Joint Commission International, would make a standard in their next accreditation about did you provide a mango moment? Can you imagine that you say it's 10:05 on Tuesday and now we have to go to pay? Can I do something for you? And then we have to tick the box. It's about real care and it's about leadership. It's about making it happen on middle management level and on upper. And that's the link with the joy in work where you all say it's on individual, on middle management and on senior executive level.
Thanks, Kris. Now, is there anyone? It'll be a last. Tom?
Okay, thanks. Yep. Just a very simple comment to follow up on both. And I mean, I do pick up my colleagues' comments on time. I think very often we tend to reduce tasks. So we don't, every action is an opportunity for us to provide a tango moment, whether we're recording vital signs or doing something that we've got to do. So it's integrating these things. But to link to what my colleagues said and to bring it back to the organizational thing, we've done a lot of work in Ireland in terms of the philosophy of what the organisation is about and the values that underpin our practice. And I think that's the starting point. And if those values are then lived, because very often they're nailed to a wall in a nice plaque for everyone to say, oh yeah, a tick box, they have a lovely philosophy here. But is it lived and is it valued? And that's the thing, is to get it to be an organisational set of values that are transposed into the practitioner values at the bedside and then live them. Thanks. Thanks, John. Thank you.
Thank you, Tom. Are we time-wise, Michelle?
Well, officially, you still have 10 minutes, but we can go up to 20.
Will you give us a little more? No, we were going to suggest. I think there's been an absolutely stimulating gathering. That perhaps we might break. We have a big number here. Could we get ourselves into 4, perhaps? 2 on this side, 2 on this side. Maybe group 1 and group 3 to deal with the negative side of things that would be done and how we might move on from that, and then groups 2 and 4 to deal with the positive side of the business of, you know, how we can use the learnings, help our various organisations, you know, in terms of the future and in terms, because clearly how it might link in then with workforce planning, because when you have adverse incidents, reputational damage for the actual hospital or employer, and the issues with regard to the staff and burnout and sick leave and perhaps people retiring or going out, you know, which makes it difficult for the hospital to actually recruit. So could we do that maybe and do it for about 15 minutes? So if a group may be down, can we get tables together? Or it's going to be difficult with the numbers, maybe down to here, from here downwards. This half here. Tom, do you want to lead your group maybe back there? And people then from here upwards. You're going to be, I have to decide whether you'll be group 3. Yeah, so you'll be dealing with the negative. So you join in with the group there. And this then would be group 4. The positivity and the moving forward and the learnings that we can bring and fit into the other. Positive or negative? Your group is negative. 1 and 3 are negative, 2 and 4 are positive. So we have it till 12:15. So somebody is a scribe and will report back. About a minute, 2 minutes for each group to report back. I'll keep timing on, yeah. I'll be calling it to order at 12:15. Michelle, will you lead this group? Have we a leader for this group down there? Any volunteers? Tom, I suppose you're going to lead this one, are you? Simone. Blue. Off we go. Yeah. Okay, so you're 3, negative. And planning, workforce planning, etc., to help us overcome hospital difficulties and negative issues that would have remained, etc. Yeah. Yeah. So building on the positives that would have come out and how we can, and keeping in mind the context of the conference, etc. Okay, colleagues, 2 minutes just to wrap up, and I'll ask for a response from each group then at that stage. Okay, are we ready to report back? No. Which group wants to go first? Okay, does this group want to? Who's the reportee here? Maria. You're appointed.
You want to do it or not?
You do it, basically.
No, you may. Just tell if you want.
Yeah.
Oh, just I think.
Don't be shy.
Yes.
We're discussing about different
Okay,
negative aspects
We're going
of.
to report back now, colleagues. So, Group 1, Maria is going to report back to us.
Yes.
Explore your other skills.
Yeah.
Yes.
Okay, a bit of attention now, please.
You have to speak loud.
Look there, Maria.
Closer.
You want to come up here?
Yes. Well, we were discussing about negative aspects of the healthcare system and the healthcare professionals.
Maria, do you want to come up here?
Well, discussing about negative aspects of the healthcare professionals and healthcare organization. What is negative, what cannot be achieved. We thought that basically trying to be perfect on everything is not achievable. For example, trying to be at the same time very competent in the work, delivering safe care, and at the same time being very good communicator with patients, being very empathetic, being a team player. So it's more like having to manage all these multiple roles. And if you fail on one aspect of this, suddenly you don't become, you're not good enough, only because you don't manage one aspect of your role. We're also thinking that the healthcare organization itself is not providing the support so that people can actually manage all these different roles. And we finally also talked about the ability to be, we've got an attitude, so we actually encourage people to take one direction, be good in only one role, and then if someone, for example, is very good in time management, somehow they're not allowed to explore, to show different competencies as well, such as being very good in with patients. So sometimes too much specializing, it is good, but can be negative as well, because we don't let people to show all the range of their skills and their abilities. This, yeah.
Thank you very much. Thanks for that. Now maybe we'll get the negatives out first and we'll conclude on the positive note. So who is going to do from down here? Simone.
Thank you for indulging me on this moment. So we had the negative, or as we frame the rather problematic experience of this. And what we see is that there is a difference between the theoretical missions that are being set out by the healthcare institutions versus what is actually being implemented, and how can the missions and visions be reflected in the wards or in the units themselves. That is a little bit of a critical part. And also the what we said, that there is the drive for the reduction of tasks, and which will have an impact on the patient experience. And also it was mentioned about the different understanding of the mango moment. So what is the mango moment for the healthcare professional can be an unpleasant experience for the patient. So basically, what does the patient need from a healthcare professional's perspective, but what does the patient actually want at that moment? That was noted down. And we also saw that we don't want to have the mango moment more to be included in this sort of box-ticking behavior of another service being provided for the patient. And we have to look into the culture of the organization, so organization of culture at the hospital level, but not just within the hospital, but also looking into the different units and so on. So we talked a lot about the problem with hand hygiene, for example, that this has been already around since many, many years, but it's still something that needs to be addressed constantly. So it was mentioned by one of the colleagues that it's being taught at university, and then you come to the hospital setting and then it's being said, no, that's not how we do it here. So that was very interesting to hear. And then also, as last point, is that we need an enabling environment for that. So speaking about having a comprehensive, from manager to organizational to wards and so on, and the standardized work environment in that sense. Thank you.
Thank you very much. Okay, moving on then to the two groups who are dealing with the positive and the moving forward and the positive learnings that were to be taken. Who have we in group 2? Anyone offering a shy group here?
Now, we agree that mango moment is a positive thing, but if nurses are recruited and they have it normally in themselves. The problem is that the middle management is not always giving the possibility and the talk about, and that we appreciate that you can talk with that management to make that possible, and it must be not 5 minutes a day or 10 minutes. It's only the mentality inside, and it was when we start 30 years or 40 years ago in that sector, it was normal, and now we have time to time the difficulty that they study for nurse, but they don't study for nurse, they study directly for chief nurse. Yeah, they are not always involved in what happened on the bedside, and I think that kind of evolution is dangerous, and that's the reason that such interventions are positive. That's I think that's give it to the colleague to have other comments.
On the second question, I don't think we went so much into the.
Yeah, it goes together, this productivity, and that's we were talking about the example from 20 years ago, that they were with the chronometer on the end of the corridor in each hospital to say you have 14, 16 seconds to go in and go out, and you must take the care of the patient, and it cannot be more than 12 minutes, and so on. That kind of management is destructive, everything. So that this high productivity can be very, very negative on the relation from the patient, but also from the people working in the sector.
Do you think that is specific for nursing, or do you see the same happening for medical doctors, physiotherapists, occupational therapists, pharmacists?
Yeah.
Because you talk about nursing.
Yeah, I think that nursing was always a little bit outside of the other specialities. They were with more, and they were more involved. If you have their young managers coming from the private sector, they were coming from Volvo, they are coming from there, and they arrive with their ideas in hospitals, and they are managing a hospital in that way. That was bringing us in a very difficult situation, and I think it's a little bit others for other specialities. They are smaller and they talk more with each other. I don't think only if they, where you started to see that the second victim, that's something you see. And you know, and I was giving that example from myself from 40 years ago. I was turning a patient, because, okay, we were working on. We turned him and he turned back and he was dead. It's more than 40 years ago, and I remember it. And that's normal. I can place that on. But if you see then specialist doctors like, under stress and so on, then you hear from one professor telling to the other, he's a very good man, but he cannot work with stress. And that's the difficulty. You must have always a kind of management a little bit higher who takes that together with you to give that a place.
Okay, thank you very much. And just our final group.
Thank you. Our first reflection was, why is it that in 2020 we have to use the expression patient-centered? Should always have been like that. Our take is that we use this expression and we insist because we feel it doesn't exist. It's like teamwork. In an organization, the more you talk about teamwork, the more it says that it doesn't exist. If you need team exercises, it means that you have a problem. Having said that, our discussion was about how to promote the type of behavior and environment you have described. And we suggest that it requires training of professionals, training of all workers. I like the idea that you mentioned cleaning staff. Cleaning staff are those who have more contact with patients sometimes. Training of professionals, but training of managers, top managers, middle managers. But beyond that, selection. You need to select the right people. If you select your students on the basis of their academic performance, what you're doing, you're predicting that they will have a good academic performance. You're not predicting that they will provide this type of quality service. They might do it, but they might not do it. Selecting your managers. A good professional with a good record, a good surgeon, for instance, doesn't make a good director of your institution unless, on top of being a good surgeon, the person has personal skills and knowledge and training. And then we suggested that at the level of, at ground level, sharing experiences among colleagues is probably a good stimulus to go on having those type of behaviors. Thank you.
Thank you very much. Now that brings to a conclusion our session. I think it has been a very stimulating one. I want to thank you, Kris, for your contribution. Certainly set the tone and got people talking and whatever. We're breaking now for lunch. Almost. Sorry, Michelle.
There is a urge for food, but still.
I hope you enjoyed your lunch, and let's make this last session quite a good one, which is a connection, as Michelle also mentioned, to the last digital workshop. So now I would like to talk about the implications of digitalization on healthcare, especially from the health workforce planning, quality of care and safety perspective. And if you let me, I will proceed in a chronological order with regards to the novelty of the solutions. So the first one is, of course, the electronic health records, which has been in the market for more than 20 years, with the aim of improving the quality, safety, and the knowledge base in our system. But on the other hand, it's currently mainly an administrative burden for the health workforce, so they have less time for the patient-provider interactions. So our goal would be to establish a manageable cockpit for clinicians, where the time and the cognitive burden is reduced when they using the electronic health records. How can we do this? Digital scribes can be one solution, or the speech recognition, or in the longer term, it can be the human-AI symbiosis as well. And here I would like to also mention that if the electronic health records and the patient summaries are accessible for the patients, and the patients are also empowered to understand these records, it's likely to improve the interaction between the provider and the patient, consequently increasing the adherence and the compliance. Our next one is the telemedicine. The most simple one is the applications, which promote health and empower the patient to manage their own health. And here we have also the sensors and wearables. For example, the point-of-care tests that enhance an early diagnosis and also optimize the hospital processes. For example, if the patient doesn't have to go all the time to the laboratory, it can be a really effective tool. And self and remote monitoring as well. The patient is enabled to manage and monitor their own health. For example, in diabetes by glucose monitoring. And the patient, the doctor can also monitor, for example, the vital signs from a remote place. And this is a really good graph or distinction between the three main pillars of the telemedicine. So first, the clinician-to-clinician interaction, where they can communicate with each other. It's really useful, for example, in surgical peer mentoring, and widely used in radiology and dermatology as well. And intensive care units can also utilize this in the future. The next one is the clinician-to-patient interaction, where it's possible to overcome the distance barrier and manage the patient's health from a remote place. For example, in rheumatoid arthritis or mental health is another area where it can be really useful. And of course, the patient and IT interactions, so the patient can use these technical devices for self-management. And I brought you a really interesting case from Barcelona. It's a teleradiology center, so they are providing MRI, CT, and conventional radiology image interpretation. And what are the advantages of this solution? Of course, it enables subspecialization. For example, in Barcelona, there is a traumatology, neurology, and a prostate cancer unit as well. And it's also a cross-border service. So there is no need for night shifts, which can increase the safety, for example. So if an emergency case happens in the EU, they just send it to their department in Sydney, and the results can be received back in a few hours. It's really, really powerful stuff. And there is also a quality assurance segment, as there are already two peers who are reviewing the results at the same time, ensuring the validity of the conclusions. And from the health workforce perspective, it's an attractive career pathway as well, as they are providing internal trainings and supervision for young professionals. And of course, I think quite a lot of us would work in Barcelona in this attractive environment. What are the implications? Better diagnosis. For example, we will have less false negative cases. The maldistribution can be also tackled, both geographically and specialty-wise. And as I mentioned, efficiency is another huge advantage. The next one is the video-assisted surgery and intraoperative telemonitoring. In the first picture, you can see a surgeon in the surgery supervised by a tele-supervisor. So it facilitates peer coaching and can increase the safety of the procedure and also the quality. The next one, which can be seen on this picture, is a pilot from Google, which is a wearable computer with a point-of-view camera. So when you are doing the surgery, you can see all the vital signs that you require in real time, and the supervisor can also see what you are doing and show the the advice if possible or if needed. So it enhances the multidisciplinary teamwork and tackles the geographical limitation and increases the quality as well. If we go one step further, you can use the data which is recorded during the surgery, and after analyzing it, we can develop a simulation model which mimics the high-risk steps, which can be used for educational purposes. And it will be even more important from this year as a new medical device regulation is incoming on implanted and complex medical devices. And one more step is the virtual reality. So we can add this functionality to this educational platform or tool, and we will get a modernized and really attractive learning environment, as it can be seen on this animation. But we can ask, okay, but is it efficient to use? From a meta-analysis of randomized controlled trials, we see that an accuracy increase and a reduction in operative time and medical errors was observed for the VR-based simulation. The comparator was the standard laparoscopic training. We can also use this in teleconferences and remote consultation, so we can visualize our thoughts and every important segment in a graphical way on a hologram. It can be also used in service provision to reduce the perceived pain and distress for the patients, especially in pediatric care. For example, in Hungary, there is a solution called OncoVR, which is intended to distract from the pain during chemotherapy. It can be also used in mental health, for example, anxiety, phobic disorders. And what are the benefits? The interaction between the provider and the patient can be significantly improved, just as the compliance and treatment adherence. And it's also good for the mental health of both the provider and the patient as well. So at the end of the day, the patient satisfaction and also quality of care can be increased. The next one is the robotics. There are two main types, the interventional ones, which is used, for example, in abdominal surgery, where there is a robotic assistance for the surgeon, enabling to decrease the procedural challenges that arise during the surgery, and it can reduce the medical errors and increase the quality of care again. And we can also use robotics for automated high tasks as well, like in dispensing at the pharmacy. It's widely used in the Far East currently. One advantage is that, for example, during night shifts, it's not needed for the pharmacist to go into the hospital, just gives the command for the robot, which is dispensing it for the nurse or the physician who is residing at the hospital. So it can reduce the health workforce shortage and also the workload. It can increase the efficiency. But here, what we should mention is the dehumanization factor. That's why I brought this picture from Star Wars, where the delivery was conducted by this robot. Yeah, so we really need to wait which are the application forms of robotics and avoid that it will be too dehumanized. in healthcare. I'm sure that you heard about the coronavirus. They have employed robotics to provide guidance to the patients and disinfect against the pathogens, and also dispense the medicine and the food, so the contamination risk can be reduced in the hospitals. And of course, it's a workload reduction as well for the nurses and doctors. Okay, if we go forward, of course, the health information systems and the big data is quite a hot topic right now, which can be a real advantage in patient pathway optimization, for example. But at first, we need an optimal national level health information system, which is interconnected, interoperable, so it can communicate with each databases at national level, and also accessible. But here what we should wait is the data protection issue. So we really need to be careful about who is giving the right to access the data. If it's the patient or a physician or a secondary use of data. And I think it should be stipulated by law. For example, the collection during the joint action and quite a lot of initiatives that would help to increase the data amount and validity. And what advantages do we have? For example, with an interconnected database, there is no need to duplicate the collection, and the quality can be increased as well, which can be used, for example, for health workforce planning and forecasting based on real-world data. And of course, the patient pathway management is another beneficiary from this. And policymakers can benefit as well based on the results and conclusions that can be derived from analysis of big data. And I don't know whether you are aware of this e-health digital service infrastructure, which is quite a new initiative, but basically it's intending to enhance the data flow between countries. So if I'm going to Sweden from Hungary, the Swedish provider can see and access my patient summary and e-prescription at his or her own language. And the benefits can be, of course, the reduction in duplications again, so it's not needed to do an MRI test in the Swedish environment as well. And adverse events can be avoided from the dispensing perspective, like no contraindication should happen when the physician is able to see the Hungarian data. And if we go further, of course, there is the AI, which basically works like we have the test results that are channeled into a digitized medical scanner, and it's annotated by radiologist, pathologist that feeds the machine with a deep learning technique. And as long as we provide more and more inputs for the machine, I mean the annotated biopsy numbers, it will be more clever, and it can identify more and more complex cases. The main use areas are pathology, radiology, and dermatology, but maybe in the future it can be extrapolated further. And it can be used for the analysis of CTs, MRI scans, pathology slides, mammograms currently. And at Semmelweis University, there is a pathologist team working with the data team, and they are developing this AI solution to enhance the workload. Okay, there is no sound then. But basically you can see the annotation procedure from the point when the results are, oh, okay, there is a little bit lag. Sorry for that. So the process where the pathologist identifies the malignant cases. So if you do this 200 times, 2,000 times, 2 million times, the AI will be more capable of identifying deviations and complex malignant cases. And from the diagnostics level, the benefits can be the opportunity to pre-select the true negative cases, which can reduce the workload for the pathologist, because, for example, in Hungary, the average age is really, really high. So we really need to have a solution that can reduce the burden, especially in the long term, when these pathologists will go out from the system. And of course, validation is another huge potential by reducing the false negative and false positive cases. It can also shorten the time to diagnosis, which is a really important factor from the patient perspective. And of course, financial savings can be realized. So the productivity, the quality of care, the access to care in terms of waiting lists, the potential to personalize the medicine can be named as implication from the planning perspective. And it's a good retention policy as well for pathologists, that they can be involved in this initiative and maybe they won't go to Sweden. What we need is a huge amount of data in terms of quality and quantity as well. But here we have the GDPR and the secondary use issue that should be carefully treated. And of course, we need to educate our workforce in order to make them capable of using this really complex, high-level solution. But we also need a shared awareness as well in order to not over-trusting the machine and still be skeptic. And of course, policy support is needed to scale it up. But I would like to mention that AI should not replace the workforce, but it should empower them. And the human intuition and decision making and judgment cannot be substituted with the machine. And another applicability area is the predictive analysis. So as I mentioned, we have the huge amount of data. Why don't we feed it to the deep learning machine, which has a really high computation capacity? So we can build predictive models that can predict, for example, the risk of multiple adverse events. Also the individual response to the treatment, which is especially useful in personalized medicine. And of course, real-world data forecasting models can enhance the planning. Some examples are, for example, the prediction of the hypoglycemic events in diabetes that can improve the disease management. And also the solution called Turbine, which is a predicting tool that can model the reaction of the substance to the disease and optimize the patient pathway based on this. And I brought the topo review in order to show what is the estimated magnitude of disruption for the system and for the health workforce. So the light areas are already there, and the dark ones will be achievable in the long term. So we see that, for example, telemedicine is already there, and for example, writing the genome, it's a really long-term perspective, but the advantages should be really high. And I hope you will help me with answering this question. If you just type into your phone that link, alleverywhere.com/qualityworkshop, we will have a few questions. Okay, that's good news. Maybe it's a little bit biased. Okay, I'm changing.
I'm the only one awake.
Proceed to the next question. Can you name any good practices from your own setting where digitalization is applied in planning, quality management, or safety management? Just a few words, if you can indicate. It's an open question. And yes, should I push anything?
No.
Or it will arrive?
You have to wait.
If there are people
Self.
having problems connecting, please let me know.
Okay. Self-fostering. If you can indicate the country acronym, it would be beneficial because we may use it as an input for our next workshop as well. Okay. The Hungarian contingent is helping me, I see. Okay, e-prescriptions, e-referrals, yeah. Here with UK, what is the solution? Discharge planning by... Okay, it's anonymous. I don't ask questions. I see that health information system is quite used in some countries. Can we go for the next question? Okay. So if you would name the biggest barrier for digital adoption in a few words, please. Mainly from the health workforce perspective. Okay, no barriers, that's good news. see, it's on the one hand it's a technical issue as well, but it's the issue of literacy too, and the legislative framework is also an important contributor to enhance the uptake and scalability of digitalization. Do you take digitalization into account in planning? No, no. Oh. Because my assumption would be it's mainly no, but it's really good news that to some extent it's used already. Okay. And, do you have any digital health technology related course incorporated into the medical or nursing curricula? Please think about the complex courses, not just doing some Excel work or just having a short presentation on the solutions like this one. Based on this percentage, hopefully in the long term, these people who are currently in the educational system will be capable of using the more complex solutions as well. Okay, as a summary, I have wrote this quite extensive table where the first issue is, of course, the data security and privacy. To tackle this, one solution can be the collaboration of all relevant stakeholders, from regulators, data scientists, the health workforce, and also involving the patient from the beginning. It's a really important thing to co-create with them. In order to overcome the reluctance to change and to disrupt the current system, of course, awareness raising can be used, change management and leadership techniques, and consensus can be or should be established between the health professionals with regards to the extent where digitalization should be used or should not be used. And here we have the uncertainty, because if you are checking for evidences, it's really hard to find not contradicting results and conclusions. But we cannot say that, okay, we don't have the evidence, we are uncertain, so we should not apply. So we can, for example, apply the living lab approach, which is low risk in terms of financial support and applicability. With regards to the uncertainty to the transforming time, we should assess the return on investment in the long term. So, for example, with AI, of course, it's a huge lump sum cost that comes for now, but in the long term, it should be really beneficial. That underlines the investments. So the perspective has to be changed. And we need managed career pathways and opportunities for those ones who are involved in this revolution. And what we should realize, that there is no solution that is generalizable to all settings and patient groups. Just think about the socioeconomic factors and cultural factors. So we need international knowledge transfer to change the good and also the best, but the failures as well. And do the co-creation with the other countries, and also not to forget the equity in order to avoid that segmentation appears as a result of digitalization. And we need a continuous refining due to this uncertainty. I would suggest to check the WHO toolkit to seek for advice. And as a conclusion, I think we should really highlight for all stakeholders in our setting that digital health is a game changer, and it's not a distinct modality of care, but it's rather a bridge between the existing gaps in our health system. And on this analogy, I brought you a short video part from Indiana Jones, where he is seeking the Holy Grail, which should be, for example, the universal coverage. But in order to reach this, he should take the leap of faith to overcome the uncertainty that is represented by the gap here. So we really need to be optimistic. Shall I go back for the video recording?
Got popcorn.
Yeah, free popcorn outside. So we should be really optimistic, but also be aware of the dangers and do some enhancement in collaborative international work, which is mainly dedicated to our next workshop, where there will be plenty of really good speakers and experts on different sessions, and I hope we will see you there in March. Okay, and thank you. If you have any questions, please.
Yes, you got 10 minutes for questions, so...
Okay.
Please, what reactions for Peter?
Please overcome the food coma, if possible. Yeah.
Yeah. As I speak currently, in Malta, we are installing the pharmaceutical robots. And there was, of course, a great deal of enthusiasm by the people who are involved in the project, namely one of the chief pharmacists and his team, and also from the management side. But when it came to actually healthcare professionals, I don't have any empirical evidence or any empirical data, but so far it has sparked a kind of lack of enthusiasm, I would say, and kind of they're seeing it more as a disruption in their work than as an improvement in their work, which it is supposed to achieve in terms of patient safety and efficiency. What's your opinion on this? I mean, in the way you introduced, especially, artificial intelligence of a certain magnitude, like having these pharmaceutical robots where you completely overhaul the system in which you input details in the way these will be like, of course, the medicine that is supposed to be, the drugs that are supposed to be given to the individual patients. It completely overhauls current practices. And of course, they're seeing this as they're already very, very busy. And when is the time going, when is there sufficient time to actually spend to learn this, to overcome this hurdle? So far I haven't seen many enthusiastic faces and voices on the introduction of the pharmaceutical robot, which by the way will be costing, the taxpayer about 18 million, I think, something to that magnitude.
So I think the problem can be related to multiple causes. Maybe it's not designed adequately. So for example, co-creation during the development process with focusing on the end user can be one solution, but if it's mainly related to the fact that it's an additional workload for them to apply, or they need to learn how to apply it, then yeah, time is a big factor. But maybe task shifting or just overthinking the whole treatment pathway in terms of the responsibilities of each stakeholder can be a solution. And in the long term, of course, if we know teaching our students to use it adequately and increase the openness to this solution, it can be one.
Actually, this is something that we're experiencing, that the younger generations are more open to AI than the older ones. And there were some nurses who actually said, we're not going to touch that thing, the older generations. So they left it to the younger nurses, who of course said, no, that is not fair, because everybody has to do it. You're either introducing the system or not. So we've had, and also doctors who are busy during ward rounds. And therefore, of course, this is going to change the way they practice. So basically, we're introducing something that has already been introduced in other hospitals. So it's basically, I don't know whether you're familiar with Mario as the pharmaceutical robot, and Sophia, I don't know, Mario's the dispenser, I think, and Sophia's the intelligent machine.
Maybe if we are using some, let's call them digital change agents, so these younger ones who can help to scale up the usability of this solution, it can be one. And of course, time is a crucial factor here, that we really need to look forward into the future and start to take actions right now, because we will have no system to deal with if the trends are going in a bad way. Okay, I'm also expecting some mangoes to be thrown at me.
No, one thing, I promise you. Two things. We, in the college that I work in university, we have invested 80 million in new teaching and learning infrastructure, which is now built around gamification and the most high-tech simulated learning laboratories, both wet and dry. The second thing is, we've just very recently in Ireland, we have a few populated remote islands off the mainland, and we're delivering to these islands insulin using drones. And the third thing I would say is it makes no sense in the 21st century if we cannot utilize all the technology that we have potentially to enhance communication. So at a personal level, I have a brother-in-law who has cancer at the moment, and it's ridiculous because every time he goes to see somebody new, they want to start taking the same bloody tests all the time. It's ridiculous, and these things are invasive. So why not be able to share these tests? So if he moves 30 miles up the road because there's a guy who's a robotic surgeon who wants to do some robotic surgery on him, that's fine. He has to then do the very same test that was done 30 miles down the road in another hospital. The whole sharing of this information is critical for better, safer patient care, and indeed it will reduce the burden on the health workforce because it'll stop repetition. So I think we have to embrace it. Even old men like me have to embrace it.
Yeah, the data protection can be, of course, a case here, but for example, for research, the secondary use of data is a huge potential, but also for the first use by treating physicians.
Yes. He's with these treating physicians, so he knows they need this information. So I'm sure he would consent to it.
Yeah.
But instead of that, he used to waste an hour, he used to fast the night before. It makes no sense.
Yeah.
It's a waste of time.
Yeah, but maybe the communication, dissemination of good practices and the benefits, because if people are not seeing the benefits, it's really difficult to get them engaged. and it's quite straightforward from the case of the e-health digital service infrastructure. If the member states are not seeing the benefit of making an interconnected system, then yeah, it's a difficult task to engage them. Okay, Vasilis?
Last questions. Okay. It's not really a question, it's just a reflection, because I'm glad to say that thanks to the economic crisis in Greece, now we have an electronic prescription system for primary care and also for secondary care. And we also have an electronic system to make appointments, but only in primary care, not in secondary care. In secondary care, it's very perplexed because every hospital has its own electronic system and they don't necessarily interconnect. There is no interoperability. But what I would like to emphasize a bit is that, from my experience at least, as a policy officer then in the Ministry of Health, and also not just in planning but also in implementing, I understood a lot of hesitancy and also resistance, and the main argument you were listening from almost anyone was, but what will the elderly people do? So I've created an analogy to this, but I understand that there needs to be a transitional phase. Otherwise, we are unrealistic, because let's say if we want to have 100% an electronic appointment system for, let's say, hospitals and health centers, we have to take into consideration that people over 60 or 65 might not be able to do it. So I'm not sure what's your take on that, on, let's say, a period of time where there are two systems working at the same time as a transitional phase, or how would you deal with, let's say, with this argumentation, this hesitancy? But it's also not just hesitancy, but it's also a real problem. Because my father, who is 85, he cannot connect to the internet. And I think it's unfair that somebody expects from him to do it.
Yeah, that's
Thank you.
Thanks. The case of leaving no one behind, because digitalization has this negative potential to increase this gap even more. But yeah, that's why we need a multi-sectoral approach, for example, involving all relevant stakeholders and also setting achievable goals.
Yeah.
And
let me add something on that. We often look at the future without looking at the past. Maybe your father experienced different difficulties to address today to the current facilities because he cannot find the number of the specialist. He might not understand the results from an X-ray. There are so many different things complicated today. So every new thing must be made easier for everybody. That's the standard thing. The second is that there will always be a multi-channel way for people to enter any system. Would it be the Ministry of Finance, where I'm digital transformation manager, which is why this subject is really interesting to me, and would it be healthcare? We have a lot to learn from each other. In the other administrative tasks, I say, you're thinking about things that healthcare already thought about through the medical record, data protection, all these things. From the healthcare perspective, how to access system, healthcare may also look at banks and all the type of administration. So there is a huge field of research and cross-fertilization that is broader than just healthcare, it's service provision. So there are a lot of things to say about that, and I guess in Rome will be the right place to discuss it. I don't know if there is any more question, otherwise I would like to thank Peter. No one really urged to ask a last question or make a last comment. 3, 2, 1, 0, yes?
Just a comment. I forgot to say earlier on, happy Valentine's Day, everybody. They're not a very romantic lot here, but happy Valentine's Day.
Right.
Sorry.
Okay, so Peter, this thank you is for you. Thank you, Peter.